his case is his talk is related to the topic which Dr. Tanna is talking about. So either before or after him, we can club it.
Okay.
Okay.
We are live now. Dr. Girish, you can start.
Yeah. Thank you, sir, and welcome to the second session of the MOA Veteran Surgeon Forum's OT is my temple, which was a great idea by Dr. Gadegone, sir, the President, Maharashtra Orthopaedic Association. After the huge and the tremendous success of the first session, this was really a great demand from everyone that we need to continue talking about the other things apart from the clinical aspects of the orthopedics. And this is a session 2, OT is my temple. Again, here we have a stalwart faculties from all around the India. And we got an opportunity to have Dr. Dhawal Desai, sir, as a guest speaker for the today's session. May I now request to Dr. Abhyankar, sir, to kindly introduce the faculties and proceed to the session.
Good morning, everybody. Thank you. Dr. Gadegone, sir, yes.
No, actually, I thanks all this Ortho TV as well as all faculties and the guest panelist, Dr. Dhawal Desai. And I am in Agra, and therefore I hand over mic to our senior most executive member and president-elect, Dr. Rajendra Abhyankar, and moderator, Dr. Sangeet Gawhale, to continue the proceedings of this webinar. Thank you all viewers of Maharashtra Orthopaedic Association, Ortho TV, all over India and the world. Thank you. Thank you very much.
Thank you, Gadegone, sir.
You can continue, Abhyankar. I will go.
Yeah. Good morning. On behalf of Maharashtra Orthopaedic Association, I welcome you all on this second part of the OT is my temple webinar. We have eminent faculties and I welcome them all. Today's guest faculty is Dr. Dhawal Desai. Then the faculty members are Dr. Tanna sir, Dr. Gawhale sir, Dr. RM Chandak, Dr. Sanjeev Bhandari, my friend from Solapur, Dr. Kiran Saoji sir, Dr. Vivek Gadge, Dr. Abhijeet Wahegaonkar, Dr. Sanjay Dhurjad from Nashik, and Dr. Vijay Ganbote, who is a guest invitee, who will be speaking on this. Really speaking, as I said, all those members do not require a specific introduction. So before wasting any time, I thank them all and I request the convener to start the session. Thank you so much. Over to you, Manoj.
Can we request Dr. Karne to address before Manoj starts? Unmute yourself.
Thank you, Dr. Sangeet. On behalf of Maharashtra Orthopaedic Association, I welcome all the faculties and the speakers for this wonderful topic. This is a unique concept, which is the brainchild of our president, Dr. Gadegone. And it has been found really very successful because it is the bread and butter of every orthopedic surgeon, that how he should maintain his OT and what are the real things which are required there. And the session is so huge that we will have 4 sessions on this. And we have got who's who faculty all over Maharashtra and even some guest faculty outside the Maharashtra also for that. And the aim of our aim is to reach to the every nook and corner of the Maharashtra, to all the peripheral orthopedic surgeon is made successful with this. I thank Dr. Pahukar and all the organizers. I thank Dr. Abhyankar, and most important, I thank Ortho TV for their unprecedented support and the great support that they are making sure that this webinar reaches to all over India as well as outside India. Best wishes and thank you very much.
Yeah. May I request Dr. Girish Motwani to start the proceedings and do the needful?
And kindly excuse me, I am starting the annual general body meeting of the Pune Orthopedic Society within 2-3 minutes. And so best wishes, I have to tell you. Thank you.
Okay.
Yeah, thank you, sir. May I now request Dr. Sangeet Gawhale, sir, to start his first presentation. So he will be talking on the C-arm monitors, cautery, and related things important in the operation theatre. Thank you, sir.
Thank you, Girish. So the topic is huge, which I have been assigned to cover, which includes monitors, cautery, and image intensifier. So since we have 4 seminars, probably I wouldn't be able to give a proper justice if I only speak on all these in short time of 12 minutes. So what I'll do is I'll cover image intensifier and rest I'll cover in the next session if the time permits. That means in the next webinars. So we all know and we have been using the image intensifier like a toy. No doubt it has enabled us to become technically more proficient. It has minimized the area of operative field. It has decreased the operating time. It has also decreased the morbidity, and whether it is used properly or it is abused like a toy, it is a time which is going to tell us. We are often underinformed of the risk of radiation exposure. These are the situations: intramedullary nailing, percutaneous K-wire fixation, MIPO, pedicle screws or vertebral plasty, where the exposure time or the exposure to the team is maximum. And we are helpless because these are complex procedures and the time required to perform and the use of CM is maximum in these situations. So the surgeons and the assistant are at the maximum risk amongst all the OT personnel due to the proximity of the CM to the exposure. More close you are to the CM, more is a radiation and more is a risk. Now, I think somebody is talking in the background. Dhawal bhai, if you can mute yourself. Normally, can somebody mute? Yeah.
Yeah.
Normally, in the day against the natural background, we receive a radiation of about 0.01 millisievert per day, which is equal to gray unit. Now, if you go higher in the air at a higher altitude, you receive more radiation. So when you are traveling by a flight, the cosmic rays at the higher altitude, we receive 0.001 to 0.01 millisievert. As you go higher at around 35,000 square feet, the dose we receive is 13 microsievert per hour, which is, I am giving you this example so that we can compare what we are getting in the operation theater and what is the cancer risk involved. Like if you are screening, Girish, can you mute Dr. Dhawal? He's making different noises. Okay. So what is a cancer risk when normal X-ray examination is performed for the lower limb, upper limb, or the joints? So the typical dose which we receive when we do the X-ray is about 0.01 millisievert, which is equivalent to 1.5 days of natural background radiation, which we receive otherwise also. Now, if you go to the hip X-rays, where the girth of the soft tissue is more, we receive an effective dose of about 0.3 millisievert, which is equivalent to 7 weeks of natural radiation, which you receive. But when you take a CT scan of the abdomen or pelvis, where the girth is maximum, the dose received is 10 millisievert, which is equivalent to the radiation, natural radiation, which you would receive in 4.5 years. So that is received in about half an hour to the patient and a little lesser to the team who's doing it, unless they are using a proper precautions. So that is the significance, that is the cancer risk, which involves when doing a normal X-ray of the extremities to 1 in few million to 1 in 2000 when you're doing CT abdomen or CT pelvis. The radiation produced while we take a APN lateral image is roughly equivalent to 0.043 millisievert per AP or PA image, and it is about double or little more when you take a lateral image because the size required is size of the soft tissue is more. I'll give you an example. This surgery I had done, it was an undisplaced intertrochanteric fracture for which I have done a DHS. And you can see here the dose report, which is available in a good CM, where you can see I had given an exposure of 1.39, and the dose which was used is about total dose, cumulative dose is about 6.87 gray or millisilverate. These are the units. That is so high if you are not careful. Now, what are the components of the C-arm? The C-arm at the bottom, if you see, has an X-ray tube, and the round thing, what you see at the top, is a collimator through which the protons or the beam is passed through the patient. It is captured by the grid of the image intensifier, and the image is then converted to a video camera. Through the video camera is transferred as an image to the monitor. So this is the basic which we should know. What are the radiation fundamentals? Surgeon rarely are in direct path of the X-ray beam. Like the X-ray beam is at the bottom of the table. Then those X-rays penetrate the patient, and then through the patient, we receive the scattered radiation. So what we receive is actually the scattered radiation which comes from the patient. Say, for example, if 100 protons are reaching the patient, through the patient, only 10 to 20 are scattered, which we receive to reach the image intensifier, and 80% are absorbed by the patient. So we are concerned about this 20% scattered radiation which we receive from the patient when we are operating. We have to be very careful about that. Now, the radiation induced injury to the skin usually is a transient erythema. Generally, it is not manifested immediately. If there is an exposure of 2 grays or 2 millisilverate, it will appear in several hours. It will peak at about 24 hours and it will fade in several days. If the dose is increased to 6 grays, it will appear at 10 days, it will peak at 2 weeks, and then it will fade away in about 4 weeks. But if the dose is still higher, more than 8 or around 11 to 12, there will be epiliation of the skin. So the greatest exposure to the surgeon are the extremities which are uncovered, the head and the neck. Radiobiological effects is a development of a cataract. You can see here in the image, it's a radiation cataract which develops like this because the eyes are not protected, or alteration in the thyroid function can lead to a papillary carcinoma because we are often not using the thyroid protection lead gear. Or you may have skin lesions, erythema, or which may develop into cancers. The effect of radiation are either non-stochastic, which because of the single high dose exposure or multiple low dose exposure, patients develop skin lesions, cataract, hair loss, and infertility. Or it could be stochastic, where it is dose independent, and that may damage the DNA, and there will be mutation of the DNA, which will lead to oncogenic change. There are several things involved when the radiation fundamentals are concerned. Now, depending on the several factors, what is under our control is the exposure time, the distance from the body part being imaged, mass of the body part being imaged, torso, and the KV setting of your emitter so that you reduce the scatter to the team. Now, these are the important fundamentals. And to reduce that, what is in our hand is we follow the principle of ALARA, wherein as low as reasonably achievable radiation should be subjected to the patient and to your team. The amount of radiation received cannot be made nil, but can be minimized by using these principles. There are various variables to minimize these radiation exposures, and one of them is your lead apron, the personal protection, the thickness of the lead apron must be 0.5 millimeters. So that reduces the scatter by 95%. Also, we have ultra thin lead aprons, wherein the thickness of the lead is reduced by half, that is 0.25. So that reduces the scatter to the surgeon by about 70 to 80%. So that is the difference. Second, the AP view, when you take, it reduces the scatter by 16-fold if you are using the lead apron. And in a lateral view, it is reduced to 4-fold. So that is the importance of a lead apron. Nowadays, there are newer aprons, which are circumferential aprons, which are available. There are also other gadgets like ceiling suspended lead sheets or table skirts, wherein surgeon can hide behind these fixed skirt, or we can use a trolley which has a mounted lead apron or a lead shield to protect yourself. So these are the various things which are available and can be used. Now, lead apron must be properly stored on a stand or hanger. You should not throw them on the table like this. If they remain folded for a long time, or if they are not handled properly, the lead in it is going to break. And usually you must have seen in those old lead aprons, the heavy part of the lead apron or the lead, it settles at the bottom when you are wearing it, leaving us unprotected in the front. So they should be routinely checked and faulty pieces either repaired or discarded. Abroad, there is an audit of apron also. That is a yearly audit to check whether the lead is adequate throughout in that or not. Second most important factor is using a thyroid guard. The thyroid collar decreases the exposure time by about 2.5 times than what you would not have used. Also, these were in market for some time, but no one practices them. They also reduce, the gloves reduce the protection by 60 to 64% if you have used a KV of 52 or less than 60. The goggles, another equipment which is useful, should be at least 0.15 millimeters or lead equivalent thickness. The goggles provide 70% reduction in the scatter to your lens or to your eyes. The other variable, and which is most important, is the distance. The intensity of radiation is inversely proportional to the distance where you are standing. Now, you can see here, the lady is standing at a distance of 0.5 meters. So the head receives a scattered radiation of about 3.2 millisieverate, the chest about 2.4, and the torso 1.2. But the same, if she shifts herself to 1 meter, it is reduced to 1/4, almost 1/4 radiation. So when the distance is doubled, the scattered dose is reduced to 1/4, and that is what one must practice whenever you're taking a shoot. Shift yourself behind so that you keep a safe distance. At 1 meter, a person will absorb about 0.1% of the patient dose due to scatter, which is very, very negligible. And this is the most important thing one must practice. Second, the scatter radiation outside the 2 meters zone of the C-arm unit is less than 1 millisieverate. So within 2 meters of the C-arm unit, the lead protection is a must. You may have an option of not wearing it if you are beyond 2 meters zone. Another important factor is the surgeon and his team must maintain a minimum distance, which is seen in this circle, a 2 meter circumference around the X-ray source, at least 18 inches from the zone of primary beam to avoid the ill effect of direct beam radiation. So near your hands, your body part should not be anywhere near the beam. the greatest exposure to the surgeon is the dominant right hand. Inadvertently, most of the surgeon, while taking a shoot, either they are holding the extremity of the patient or putting an implant or a guide wire, and your hand is directly coming in the path of the beam. So that increase in the exposure dose of the extremity with the exposure time increases the risk to the surgeon, and one must not practice that. Stand away, remove your arm, you remove your hands of your assistant and yourself away whenever you are shooting. Avoid direct handling of the X-ray tube, which is usually at the bottom of the table while in operation, or placement of the hand directly in this radiation beam. Very often, the grid of the image intensifier is used as an operating table, particularly in hand surgery, as it is easier to position on the flat surface the hand and to get a clear quality of the image. Mind you, it is a dangerous practice because underlying the aluminum surface of the plate is the vacuum tube. If penetrated, it will result in an explosion and potential electrocution of the operator and the patient. So that must not be practiced. Usually the collimation or the collimeter is this round part of the X-ray tube, which is at the bottom, through which the beam of the X-ray is picked up by the image intensifier through the patient. Very often when you are moving the C-arm under, so this is damaged. Now, and if this is damaged, there will be a misalignment between the X-ray beam and what is being captured by the intensifier. So that will lose the contrast of the image. It will increase the noise of the machine. The image will be degraded, and to shoot, or since our C-arms are automatic, it will require or throw additional dose to the patient, and it will increase the scattered radiation. So this part of the X-ray tube must not be damaged, or if there is a loosening or misalignment, get it checked with the engineers. Now, position of the X-ray tube should always be under the patient, under the table, and it should not be above the patient, because you can see here, if it is under the table, the green zone is the amount of radiation in the air, and the same when the X-ray tube is above the patient, you can see the area of radiation in the air what one would receive. So that will increase the scattered radiation to the T. So one must not practice 2 minutes
to go, sir.
Yes. So second important thing is whenever you're placing the X-ray tube underneath the table, the height of the table should be closer to the intensifier. So that will give you a low exposure and a good image quality. If the table and the patient is closer to the tube, the exposure will be higher, more radiation will be required, and the image will be blurred. In a lateral view, what happens is there is a higher girth of the torso, and a higher radiation is required. The surgeon must not stand opposite the X-ray tube like this in the first left picture, picture A. One must stand towards the X-ray tube. That reduces the radiation to the surgeon by 5 times. Bring the intensifier as close to the torso so that you reduce the radiation as well in this situation. Remove or reduce the implants, the metal implants like the retractors, the spikes, or implants which are not required, because the machine will increase the radiation dose if there are metals, to improve the quality of bone. In obese patients who have very thick abdomen, who have thick hips, obviously the radiation dose required to image the bone is very high. So that will give rise to increased scattered radiation. So in this situation, particularly when you're operating in an obese patient, add protective devices or keep a safe distance from the patient. The intensifiers or of the size of 6 inches, 12 inches or more. Larger the diameter of the intensifier, lesser is the dose required for penetration and lesser is a scatter. Often we try to move the C-arm in the AP view, and when you try to check it in the lateral view, again you move the base unit of the C-arm. So what you can do is you can put landmarks, either a tape or a marker on the wheels. Once you fix, take the first shoot, just move the C-arm, the arc of the C-arm. You don't have to move the machine, thereby reducing your shoot. Also, laser imaging device, laser aiming device is available in some of the C-arm, which can be used to focus on the area where you want to shoot. That will reduce the number of shoots. Image capture. You have always a second monitor which can be used to study the last image what you have shot, so that you reduce the number of exposure. And second, there has to be a language protocol between you and the technician, so that you reduce the number of shoots. Also, one must practice what is available, something which is available in most of the C-arms, that is an intermittent fluoroscopy or a pulse mode, rather than using a continuous fluoroscopy. Usually in this, there is a 3-second burst with a long off interval, and that reduces the radiation dose by 70%. So developing a communication skill between you and the OT personnel will reduce the exposure time significantly. A decrease in the efficiency of C-arm unit is compensated by increasing the exposure to get a similar brightness and contrast of imaging. The amount of radiation delivered varies by more than 100% in more than 30% of the machine at the 1 year interval. So that is the reason the refurbished market has come in the vogue. At 3 years or 5 years, most of the C-arms are discarded for the same reason. It increases the amount of radiation to the OT personnel and the OT team, and hence it should not be, if you have to use them, always a check by the engineer and adequate calibration is required to reduce the number of exposure. A dosimeter, whenever you're using, should not be used under the badge, or it should not be stored outside in a normal air. It has to be stored in a lead boxes. And your aim is not only to reduce the number of exposure, to reduce the number of cumulative dose, but as well to reduce the number of time exposure is required. The newer C-arms have a 360-degree rotation, as against the older C-arm, we have only 135 degrees of rotation. So this is useful, particularly in saving the time. To conclude, what is in our hand is a scattered radiation, and that can be reduced by following the principle of ALARA. X-ray tube should always be under the patient and under the table. Use a pulse mode whenever you're doing a continuous fluoroscopy. Use landmarks on the floor or on the patient depths, or a laser beam to reduce the number of shoots. Use proper and adequate protective gear. Avoid your hands coming in contact of the beam or direct exposure. Develop a good communications language between you and the radiology technician. Shout, shoot, shoot whenever you're shooting, so that you save the anesthetists, the nurses, the ward boys, and the OT personnel from unnecessary. Some of them may not be using the lead aprons. And lastly, an important slide. When the atom bomb was thrown in Hiroshima and Nagasaki, it destroyed everything within a zone of 3 kilometers. And the radiation from the nuclear bomb was 500 to 1000 millisievert. And that is equivalent to 50 to 100 whole body CT scan. So just be careful of what we have discussed and try all possible ways to protect yourself, your OT staff, and the OT personnel. Thank you very much.
Thank you, Sangeet sir, for the eye-opening talk. And this was really a great information about using the C-arm, where to stand, how to avoid the radiation. We can take few questions, sir, before moving to the next presenter, Dr. Kiran Saoji. Yes, Sanjeev sir.
Yeah, I want to just say that out of all these things for Alara, I am insisting for last 20-25 years of a laser beam or a pointer, because I feel that out of 4 or 5, only one shoot is really good. You have to move, pudege, magage, just move to right, move to left, and then one shoot you get. So 1/4 you can reduce to 1/4 or 1/5. If you are first focus it on the point where you want to shoot, and then you shoot. This is what my observation has been for over the last 20-25 years.
But for many of the C-arms, they don't have an inbuilt laser aiming device.
So one of my friends here in Solapur, young orthopedic scientists have developed something like that. And I, after Mr. Shashank Sabu for this Medtronic who had supplied the money, I'm telling you, you develop this simple thing and will reduce the radiation a lot.
Or probably those who have a newer C-arm, they are unaware of it.
Yeah.
I'm sorry to say this, but there are many things like the dose report you must check at the end of the surgery, which is available in most of the C-arms.
Dhawal sir. Dhawal sir, please.
Yeah.
So like just practical application of what you talked in this lecture, like suppose you're doing an uncemented THR and you will be probably seeing the acetabulum placement one and the femur placement once or twice. Do you wear a lead, or you recommend to wear a lead apron, or you be
Always.
okay?
Or
You
move
always-
away. Or move away.
You stand 2 meters away whenever a shoot is taken.
Okay.
Yeah. So when really we are not taking many shoots, sometimes it is better to just move away, because that lead cone is a really heavy one. So it's better that we move away from the thing. Yes.
Sanjay.
One
Sanjay,
thing I want to just
Sanjay,
add.
Girish.
Yes, sir.
There is a request from Dr. Tanna sir that he has some other commitment. If his lecture can be taken now.
Yeah. I spoke to sir. He is ready with the presentation.
And followed by Dr. Bhandari, because it is related to that.
Related to this,
And we
yes.
can follow the normal sequence.
Sure,
Sanjay,
sir.
your question.
Yes, sir. No, I just want to add one thing. What I normally practice is that I have the control of the shooting with my own self. I use the foot pedal. So that I am very much sure that once the placement of the C-arm is at the right place, then only I shoot. Because if the control is with your assistant or with the person who is there, he might keep on shooting and he's not aware whether you are ready to be shooted upon.
But Sanjay, you will agree, whenever you are in a stress, you know what happens? You go on continuously shooting and use as a toy. Whenever you're not you're struggling, at that moment, everybody behaves the same way. Whenever you're not getting what you want, we all are different then.
That does happen.
We are worse than the technician.
Yeah, thank you, Sangeet sir.
I can ask Sangeet.
Yes, sir.
Yes, sir.
Of doing a MIPO and a closed joystick reductions, which some of the surgeons, particularly I'll quote Gadegone, really is expert in all that. How much you think he is risking exposure for those real long time MIPO and joystick which he is doing?
Sir, I answered that it is a struggle to get a close reduction. Most of the times, I would abandon after 2-3 attempts and open formally to get rather than struggle for a close reduction or doing a MIPO.
I would say in an intertrochanteric or a subtrochanteric area, opening up the fracture does not jeopardize the healing. If at all the healing is jeopardized, it is in the shaft femurs. But in a subtrochanteric region where there is no need to really go on working too much with the joystick things, you as well open it up and you will not have to know any theory of how to rotate the fragments. You will be able to do it all yourself just by seeing the 2 fragments of the fracture.
Yeah,
So
thank
it
you.
jeopardizes the ego of the surgeon. अरे मैंने close किया 1 centimeter incision, 2 centimeter incision in an 80-year-old man. I mean it. Is there any really significance that you are taking so much of radiation? Just open it and do it properly.
Yeah. Sanjeev sir, we need to move to the other presentation. May I now request Dr. Tanna sir to please talk on the very important topic, management and the training of OT personnel. I think it's very important in small setups and the small nursing homes. So Dr. Tanna sir, please.
Yeah. Can you see my slide?
Yes, sir.
Okay. The training and management of an OT staff in a nursing home setup. What I am talking about is 15 to 25 maximum bedded nursing home. What do we need in such a small place? We talk about one main OT nurse. Second OT nurse to fill in nurse when the main nurse is not available, either sick or in transition. 2 ward boys who can manage instruments and CM. In a small setup, there is no radiology technician who manages the CM, but the ward boy does it if he is being trained enough. And 1 circulating nurse if it is needed. This is the staff which we need in the theatre. In small nursing homes, same OT staff also works in ward and OPD. So I am going to talk about their full training and full duty management, and not only in the as far as the OT is concerned, because he is the all-rounder. He or she is an all-rounder who works all over in the nursing home. In big hospitals, OT nurse and OT boys do not do any ward work. But in small setup, all do almost everything. Many come and go. But once you find a proper one, a perfect one, 1 or 2 nurses and 1 or 2 ward boys, just paralyze them. Salary more than anyone can give. Honors and prestige is the same small setup. Now salary, when you are starting off early, you feel that if outside they are getting say 20,000, how can I give her 30,000? But I feel in a long run, as an orthopedic surgeon who has a nursing home, only 1 or 2 people to paralyze with their high salary will not really affect the economics of even an earlier part or earlier days of any nursing home. So I would strongly suggest that see that they don't go away anywhere just because of a small extra money. And the honors, that is one of the major things. Honor and the prestige is equally important to those people who are working in a small nursing home. And hence, the main nurse gives the charge of a small money, he or she feels important. If she can spend those small money, and then about the salary one side point, I remember one of my OT nurse was getting married, so she had to leave the job. I tried to place her in an appropriate job. I went to Jaslok Hospital and asked the dean of the Jaslok Hospital that she is an excellent orthopedic OT nurse if you want to employ her. He was very happy to keep her, and just by the way, he asked me, yes, sir, how much do you give salary to this girl? When I told her the salary, he had a hearty laugh and he says, doctor, our OT nurse don't even get about half of what you are giving. So this is the one which I want to make it a point. Only one nurse you can do it. In big setup of Jaslok, when everybody is a nurse, the staff nurse or a senior nurse, they cannot do this upgrading of that at all. So I suggested them, don't keep them as an OT nurse. Keep them as an OT assistant. Then it's a separate category altogether. But then obviously it was not practical. The main nurse is supposed to ask for replacement of all items. Better computer setup for this. Nowadays it is much easier to do it. But otherwise, you do not bother about such small things. It is her responsibility to whatever you have used it or whatever is needed, she will do all that. But make a show of checking the account once in a while. Show. So that she knows it is monitored. Don't just leave everything to her. Do not bother about small discrepancy. Tell her him or that in a busy work, it might have been missed. Do not worry about it. Chief nurse should look after the duties of other staff. New recruitment, bonuses, increase of pay, all that. So she or she gets the prestige and power over others. I feel this is one of the most important things. If she has been given the prestige and power and the salary, she'll never leave. In last 40 years of my nursing home, I had only 3 nurses, main nurses who were there. And the other 2 who left, they only left because they got married and they started staying in suburb. While the last nurse was getting married, and I provided her with the quarters. And I think all those who have worked with me, she is there with me for 30 years with her husband and children and everything. So I feel that if you train a nurse and you keep her and give her a prestige, she will not leave at all. Training of the staff, this is one of the most important things what we're talking about. Never leave to your assistant. I remember my assistants who were there all the time, orthopedic surgeons as my fellows, they would enthusiastically teach the staff. One must spend time to teach a potential long-time client. He or she will have to give instruments on your signals and not on your oral orders. Most of the time, if she is seeing the operation, she'll be able to give it. OT nurse must be able to see the operation assisting. I feel this is one of the most important things which I very insist on. She should not be pushed in second line by an ortho assistant or an ortho fellows. So every time she can give instruments only on seeing the progress of the surgery. So she has to be in that. Now here is the surgeon, here is the first assistant, here is the second assistant, but here is the main nurse. She shouldn't be at the second line where she doesn't see anything and she gives the instrument, which happens in almost all the 5-star hospitals I work. She doesn't see the operation. So she cannot give you the instrument pure by it. While in a nursing home, all those who have worked with me, you know, you are just putting the adjustment and you put in the plate. She knows very well that now you need a sleeve and the drill. So without asking, she will give a sleeve and a drill. When new assistant comes, she will be a lifeline in the OT. Like I described, I was doing a spine. And you know, when you are doing a spine microdiscectomy, it's a small area which you're doing and you need the suction exactly at the same spot. New post-MS resident or an assistant who has come, he has not learned that. So me and my sister look at each other. She takes that suction for cleanser me. I just fully clean up and give you the suction. She takes the suction and she will suck it without even giving it to the assistant till the time that disc is exposed, that disc is out, and immediately he'll give it to the assistant. Most of the time, the assistant doesn't even realize that she has taken up the suction herself because she was trained. You had put her there all the time in the OT, doing small things, not only giving you the instruments when you are asking. She retracts it, she puts the spike, she does all sorts of things there. Over the time, my main nurse, which were 3 in 40 years, were the main backbone of the whole setup. And all of them could stitch up the spine after I have finished pedicle screw. So many times me and my assistant had to leave. So after a pedicle screw, she will close the muscles, she will close the subacute, and she will close the skin. She was trained to do all that thing over the time, and she has to be doing it. Officially, number 2 in the setup will be ortho assistant, because he is an orthopedic surgeon, so he is number 2 in the assistant. But practically, create an atmosphere so that the main nurse who is there for a long time remains almost equal. But she gives respect to the ortho assistant and listens to her for most medical issues. Ward boy who works as all-rounder in the setup. He sterilizes the instruments, collects specific instruments for a stage surgery, can manage CM, can adjust lights, can give drugs, etc., etc. He sterilizes the instrument, manages the CM. Give him occasional bow by asking him and appreciating a job. Occasionally ask him how much exposure for this hip you gave for such a clear picture, and you will see him getting mahakush. I think all these are you have to manage them, push their ego a little more, and you will get the best out of them. No tradition of fully paid 3 weeks leave in a year. I give them choice. Instead of a yearly 1 month, that is a 1 week extra leave pay, I give it to all. But when they take leave in between, salary is proportionately cut. They will take bare minimum leave only if they need, as they know that they can earn extra by working. If they have not taken a leave at all in the whole year, but still they will get a one month of leave salary. And I find, I do not know if legally permitted, but I ask casually a labor law officer and he says it is okay unless it is objected upon. Diwali or Eid and or a New Year, whatever you celebrate, give equal bonuses to all. I insist on equal bonuses, whatever 1 month, 2 months, whatever you give, by check, which is seen by all. But some key people, give them extra secretly. No one else is supposed to know. Even 2 people you have given, they shouldn't be able to know how much the other person has received. If ever they talk to each other, you come to know, penalize them mildly, but firmly. Labeling the instruments done by nurse or a ward boy who is going to take it out in their language. You know, I think quite some of the nowadays, most of the ward boys can read or write English partially. But if they cannot, still they have to label it in their language. Like, and when you ask for instrument, like odd instruments like that, Nagpur nami anla hota to, ki to jo Babulkar sahab ne aapnala dila hota to, he will understand exactly what you are asking and he'll be able to give you those instruments when you are working. The key people, if occasionally inquire about the family and children, and at times pay treatment charges for the illness in the family, direct to the hospital they are treated. This is not an agreement of hiring, but a goodwill of a boss. Key people, if possible, pay for education of the children. But my experience is just a lump sum amount, not the actual expenses. This goes a long way in buying their loyalty. Now I'm talking about all these things can happen only once you have established and you are earning more money. But even I feel even the early phase, whatever kindness you show to the staff, they will hang on to you and they are the big asset to you. Mainly, they all contribute to your wealth creation. I very openly say, most of my staff have really been part of my wealth creation. And they really give you, I'll give you a few examples of that. Even if you get angry in a heat of a moment on any junior staff, always go and apologize. They'll feel better and will say, sir, please do not do this. But you will also feel much better if you apologize. Do not your ego overtake a human behavior. Never reprimand a senior in front of a junior. This is the one thing you must understand, because the senior must feel really the all-powerful senior. And here is a never reprimand a senior in front of a junior. And here it is, one of my friend's wife told his husband, even when I was there, always shout if you want to shout at those who can shout back if you have guts. But no, we are meek people. We brave will always shout and only those who cannot give you back, to our ward boys and ayabai. You will never be able to shout at your assistants or at your equals. Put in charge of the phone answering one who can talk better in the local language. Give him importance and let him say in phone with authority, "Bolo aapko kya chahiye? Hum yahan ke in charge hai." Your family person who is kind can help you in administration, but you must keep the final lagam with you. Do not let him or her dictate, give all the terms. Send many staff on paid courses by you. Send many staff on paid courses by you. It will bring a fresh air and ideas in your working. They will feel great doing a course and will even suggest you new things which you must consider and compliment. Never flirt with the hospital staff, at least in the nursing home. This advice many may not be able to practice. I'm sure about it. Main personnel should manage in OPD. And see, all these girls and all these really highly efficient people also manage the OPD. Those who have developed in OPD, those who have developed complications are immediately taken in a different room and do not let them talk to other patients or call them at a different time. Let that nurse manage, trainer to give extra bhav to VIP patients. I think Sangeet has worked with me. He knows it very well. Generally, the complications, if ever it comes in your normal routine outdoor, she knows it very well कि इसको infection हुआ था. And before he talks to your other patients, immediately he is taken into the side room where I had 3 rooms, and he is treated and passed off immediately outside the gate. And yet I remember one VIP patient, one Don came to my clinic, and he introduced himself. I am Mr. So-and-so. Tell doctor I am Mr. So-and-so, please take me early. Very politely he tells him. When she realized it, and she comes and tells me, sir, that Dada so-and-so has come. So you take him immediately, she will be able to give that extra bow to him. He says, he went back to the patient and said, sir, as soon as this patient is over, we'll take you. And he makes her sit into the front room, which he doesn't feel that he has been treated not properly. And those who have excellent results in your nursing home, let them mingle longer with new patients. Delay their turn. And they are very happy to talk to people who have come for the first time. And they will talk, "Arey, dekho, hamara operation hua, itna bada ho gaya." And he will not even mind hanging around and really talking and chatting with those patients. When you have quoted a fee, this is the one which I have practiced again and again. When you have quoted a fees, patient still not comfortable. Patient is going away because he feels the charges are more. When you have quoted a fees, patient still not too comfortable. Patient is going away. You want to do that case for whatever reasons. Ask your trained nurse to politely inquire. You must not have said, and she will tell you this is what exactly she said. You must not have told the sir that you want to do it in general ward, because in general ward it is cheaper. How does he know which class you want? He has quoted you for probably a single room. And if you want to really do it at a cheaper rate, ask for a general ward. She is the main person who will make lots of money for you. And I know that my nurse always convinces that patient and at a cheaper rate, and you are willing to do it because it is interesting. I stopped charging for small items here. Item-wise, I charged ad hoc. Because one of my good friends came, he said, Dilip, by doing my operation, you gave me 10 IV drips. Just check it up. Your staff is not earning money out of that. No? So I realized it. And then I said, only items number XYZ charge. No detailed billing for them. But insurance patient is a different thing. You may have to do it. Initiate main one or two people to earn extra by stocking belts, etc., home visits to remove futures, etc., etc. Gifts given by patients to see that it is distributed to all, even those who are absent on that day. Mainly discourage and fire if they take tips from patients. Especially, they will not hang around with the discharging patient, which is very, very uncomfortable for the patient when they go out. Before going on holidays, bring all staff and open up all instruments and show them some which they are not familiar. You also will know what you have. I think to my utter surprise, at the time of closure of my nursing home, I realized I had 7 drills, I had 5 oscillating saws, and I don't need all this. So many instruments triplicate. It was not by design, but I just went on purchasing because I didn't know whether I have it or not. Conclusion, long-time staff is a boon in a nursing home setup. Learn tricks to keep them without marrying them. Must remember they are contribute to your wealth. Those who are there long time, even buy a house lavishly, must remember they have contributed to your wealth. So they deserve something more than normal on occasions and on Diwali. Give them. Thank you very much.
Yeah, thank you, Tanna sir. It was a great talk, and we can have few questions before moving to Dr. Bhandari sir. Yeah, Manoj sir, any questions on chat box?
I don't think so.
The crux is just that old is gold. Retain your old stuff and you will be more comfortable and happy.
I'm sure everybody does it in their own way.
Yeah, yeah.
I'm sure those who have small nursing homes, which is quite a lot of you have to learn those tricks of keeping the staff there as long as you can keep.
Yeah. Sir, can you stop sharing your screen so that?
Yeah, Sanjay sir. Sanjay sir, please push.
You're muted.
Unmute yourself, Sanjay sir.
Sanjay, you're muted.
Okay, sir. Yeah. So my question is that you have talked about the nursing staff and the OT staff. What about the administrative staff or the accounting staff? Have you have any experience about that? Those people who have where they
in the small setup, I didn't have an administrative staff at all. My main nurse would do everything. She would manage money. She would put in the bank. She will do everything, and that is the way she also feels prominent about it.
Okay.
Do you have an administrative staff in a 25 or a 20-bedded nursing home?
No, sir. We are the
at least a receptionist or a person who handles the cash or finances.
Yes, Sanjeev, you were saying something?
Yeah, we ourselves are the main administrators. Our wives are the second administrators of the staff. And as you said, लगम अपने हाथ में रखो, sir. लगम अपने हाथ में रखो, नहीं तो they are very strict and many people leave. So secretly giving something, etc. is correct.
Now, can I come in, sir?
Yes.
Basically, I also own Unmesh Mahajan. I own 20-bedded hospital, but I have 4 administrators. One is accountant. One is the manager who handles the cash and gets the admission, everything sorted out. One is housekeeping. So that keeps me off all the burdens of my work apart from orthopedics. That's it. It works very well.
As I said, in my nursing home, I only give money and take money. I do nothing at all. Absolutely nothing at all. Those 2 nurses, they all manage. And as you said, accountant, obviously, it is the part-time accountant who comes and does accounting. The other things, I think, are day-to-day nursing home things. I felt that if somebody comes, there will be a conflict between the main nurse and the administrator, which I didn't want to do it. So everything was handed over to main nurse, and she was very happy to do all those things. I think Sangeet knows very well about all those things which I am talking about.
Sir, accountant or cashier. Accountant,
Sir,
cashier. I have a question. Accountant or cashier, whom should we employ, and how do you check?
I think, sir, if you are doing my point is, if you are paying so much for them, they really work well for you, because when the patient comes and gives you cash, you always ask for discount and everything. But if the manager collects the money, they never ask for discount, or they don't give discount as much as we give in as easily as possible. So you earn more money. You earn more money that way.
That is exactly what happens. As you said, I don't collect money, but it is collected by the secretary outside.
Yeah.
Yes.
Secretary outside, and she makes the receipt. I'll tell you, after I had an income tax raid, every patient is given the receipt. Occasionally, the patient himself says, "Sir, humko receipt nahi mangta hai," and then also he makes a show of giving a receipt. But then she obliges him by not making a receipt. But otherwise, you make a receipt for everybody. I think in the law, but 1 or 2 people whom you do not want to make a receipt, you just collect money and send the patient away.
सर आजकल तो बहुत लोग जीपे और पेटीएम से पे करते हैं, वो अपने आप बैंक के अकाउंट में चला जाता है.
After the lockdown, the things have changed completely.
Yeah.
You have to have.
No, I believe.
You have to.
I believe a full-time accountant is must for good hospitals.
Agreed.
Often, since you all have nursing homes, what is the policy of giving discount? It is on the total bill, how much percent, or it is on the surgeon's fees, or it is individual? Yeah,
percent to person.
Sangeet.
Yeah.
First thing which I do is that I have got an estimate form for my hospital patients. Whenever a patient gets admitted, I have broken it up into the hospital charges, including surgeon charges, anesthesia charges, implant charges, and others. I tell him this was the expenses. Then I take it in writing. I sign it that 2 relatives of the patient and 1 relative signs that. And so I know that now I'm going to collect. One more rider is in the end, that if anything unfortunate or unforeseen occurs, we will revise the estimate form. It happens hardly 5% times. So once we sign both these things, I'm sure that I'm going to get 50,000, 40,000 from this patient. Then we usually make a bill of 42, 43,000 and then show that you are given 2,000 discount and collect 40,000. So he is happy, you are happy, and 99% my patients go smiling when they go. Otherwise, I have seen a lot of things happening at the time of discharge. People are unhappy.
Sangeet.
Yeah. In Bombay, as you know, our bill goes to 1.5 lakh, 2 lakh minimum for everything. So this patient, I think he had a bill, he was in a single room, bill was 3 lakhs plus. And I knew that they were in a single room, they were well-to-do people, but at the time of going out, they always come to your clinic when you are busy, when there are 10, 15, 20 people are waiting outside, they come inside and ask for a concession. So you have to give it, because if you don't give a concession, then it is going to be a very ill feeling. So
thank you, Tanna sir. Thank you, Bhandari sir, for the great talk. And let's take
Dhawal sir wanted to make a point.
Sangeet, there are two quick lines. There is what is called as the feel-good factor. So I think every patient wants a discount. So you have to have that counted in your quotation or your bill, because you're always happy with this thing. Second is, I think, trust your staff, because once I was very benevolent to this patient and my staff said, sir, आपको मालूम नहीं इसका ऑमलेट का बार ला रही है, उस पे कितना बिजनेस करता है. So sometimes you have to take the word of your staff also when you give the discount, I think.
And a trained staff always give you the idea about seeing the patient and talking to the patient कि ये बदमाश है, ये discount मांगेगा, हाँ sir. आप पहले
that idea is always there. पहले दिन आता है ये साला बहुत चैप्टर है आदमी.
Yeah, let's move to Dr. Kiran Saoji sir, because it's a request. It's a request from Dr. Kiran Saoji. He's already committed to some other program.
But sir, 1 minute.
Yes, sir.
It is in line with my thing. ये preparation of patient के पहले का है मेरा sir. तो वो line backup हो जाएगा, please.
Dr. Kiran sir, can I move to Dr.
No problem. My computer is getting. Okay, no problem.
Yeah. So Sanjeev sir, you can start your presentation.
Yeah. Thank you very much.
Okay.
So may I start?
Yes sir. Sure.
Yeah. So friends, till now we have really known a lot of facts about an setup of an ideal OT. How an ideal OT setup should be there. But once the OT is set up and we are start functioning of the OT, now let's know, while you are preparing to enter the OT, what standard operating practices and guidelines are there for an operation theatre. During my 35-40 years of experience working in various setups like a government hospital, a big corporate hospital, or the cooperative hospitals, and also working in many small and medium-sized nursing homes, I was really very disappointed, and really everybody should be seeing this, that it is common to see either lack of knowledge or utter disregard to the various OT protocols. The surgical site infection is the one about which we are all worried, and it accounts for nearly 20% of the nosocomial, that is the hospital-acquired infections. And this surgical site infection is mainly because of the intraoperative contamination of the surgical wounds. And as we all, as an orthopedist, we all know that this SSI can be very disastrous for our branch especially, because the whole good work which you have done can be spoiled by this surgical site infection. The best part of it is that various reports suggest that with proper protocols, this surgical site infection can be brought down to as low as 0.3%. Now, what are the ways to reduce this intraoperative contamination of the surgical wounds? The first two things, that is the ideal OT setup and proper sterilization of instruments, equipment, implants, have already been covered in detail in the last masterclass. And so I will not go into that detail. My job is to see how OT discipline should be there by all OT staff. 1 second. One minute, please. I just want to keep this away from, yeah. So OT discipline by all OT personnel, and this OT personnel include the surgical team, even the anesthesia team, and all paramedics, as Dr. Tanna said, the main nurse, the ward boy, and other circulating nurses inside the operation theater. All these things are equally important, and they are not exclusive of each other, but they are rather complementary to each other. So that if an ideal OT setup is there, but the OT staff is not disciplined, they are entering inside, going in without a mask, coming out, then you cannot reduce the intraoperative contamination of the surgical wounds. Now, coming to the guidelines and standard operating practices for OT staff, we have to consider in two different or the three different ways. One is the Western standards. The WHO has got recommendations for reducing the surgical site infection. The CDC of USA has also got multiple guidelines for reducing Western site, and there are many articles which suggest various Western standards which should be followed. But we have to consider them in context of our Indian scenario. Again, as Dr. Tanna was saying, there's a difference between a corporate and big hospitals where there's an OT complex. There's an OT specific staff which manages the operation theater, and you don't have to see that. But in a small and medium hospital, you are the captain of the ship. You have to really see that all things are managed properly and the OT staff follows the OT discipline and protocol. Otherwise, there will be a mess. So really, well, last time also I have said that can really MOA come out with OT guidelines for MOA members, especially for small and medium-sized nursing homes, where we can define them in three different categories like basic minimum requirements. It was also discussed that this is more important from medical legal point of view. If suppose some infection occurs, the patient goes to the court of law, then the court will ask whether there were basic minimum requirements were there, especially for small and medium nursing homes. And then of course there are desirable things which you should really try to implement if you can put them inside. And of course, most ideal setup and standard operating practices, if you can follow them, there's nothing like that. Now, guidelines and standard operating practices, we all know, but really three things I want to really ask you. Are we really teaching them to our OT staff? As Dr. Tanna was saying, most of our OT staff is either 12th pass or maybe BA, BCom, but we really many times don't have the staff who have done their OT assistant course or some paramedic course. So it is our duty that whether we teach them what is to be followed when they are entering the operation theater and what precautions they should take. And if at all we teach, do OT staff follow them in reality, especially in smaller setups when you are not there, when you are not looking over their shoulders, whether really they follow the OT protocols. And lastly, whether we are monitoring their compliance, what we are doing to see the compliance. Long back when I was working in the civil hospital, I came across this editorial in the Delhi Journal of Orthopaedics, Journal of Delhi of the Orthopaedic Association, written by Professor Lalit Maini. And here he had really said that do operating room need guidelines, and he had given various references, various guidelines, and what ideally should be there. I thought, because I was working in civil hospital, I knew that there was really lethargy regarding these all protocols. And so I got jumbo xerox of these 2 pages done and printed them outside, pasted them outside my operation theater. At least the residents, anesthesia and the orthopedic residents will read them and follow them to certain extent. And then one more thought come to my mind. All the time when we call it OT, in 2005, I thought that when we are calling it OT, it says that it is an operation theater. It is an operation theater, and you know that really in a theater we don't follow any discipline, or we are not entitled to follow any discipline. But just change the nomenclature to operation temple. Now, when you call of a temple, whenever, even in the thick of the night or middle of the night when nobody is looking, still one will remove his shoes. One will, if the clothes are dirty, he may change his clothes. In some temples, they wear the headgear. You wash your feet when you are going inside. It is not from by enforcement, but it comes from within. And so I thought that this is the best thing. And so I taught my staff and my residents that don't call this operation theater, which is a Western term. Call this as the operation temple. And then the whole, I feel that it has changed a lot in the minds of my OT staff as well as the residents. And when I had a talk with Dr. Gadegone in this January, I told him that this is a concept which I had taken out about 15, 17 years back. And he liked that, and I'm very happy that he has named this really all webinar as a OT is my temple. This, thank you very much, sir. Now coming to the guidelines and standard operating practices for the OT personnel, I will describe them under 4 different headings. That is the OT attire, which includes the OT dress, cap and face mask, and footwear. Then the OT traffic and number of persons, which Dr. Sandeep Patodan last time had really touched upon it. Then scrubbing by the surgical team. What is the ideal way of scrubbing by the surgical team? And after scrubbing, the proper donning of gown and gloves. The CDC has said that the human body has been recognized as the major source of bacterial contamination in the surgical and operation theatre environment. When they really isolated the bacterial cauteries from surgical site infections, they were traced to the hair, nasopharynx, and skin of the operation theatre staff. Skin swamps and the nasopharyngeal passages, they are the primary source for harboring microorganisms responsible for cross-examination. And so they suggested that wearing a proper surgical attire and proper hand scrubbing before surgery have been shown to aid in containing the shading and dispersal of skin swamps, as well as the bacteria from the nasopharyngeal passages into the OT environment and the surgical wound, and thus reducing the bacterial contamination and surgical site infection. So all the staff and the personnel who are entering into the operation theatre, their bodies are the primary source of infection. And so we have to really have very good guidelines and protocols for them, even if you are not there. Now, Bannister et al. Have said that coagulase positive Staphylococcus aureus are present in the nasal passage of 40% of the, nearly 40% of the OT staff. And if there is no barrier like a mask, then they can be dispersed into the OT environment by sneezing. About 3.9 lakh organisms are spread into the atmosphere by sneezing, while by coughing and speaking, 710 and 36 organisms are given up out in the OT environment, and they settle into the surgical wounds. Wearing a surgical mask leads to 40-fold reduction. Why I'm saying that in between, about 15-20 years back, the anesthetist had really, there was an article in the anesthesia journal which said that anesthetists don't need facial mask because they are away from the surgical wound. And then there were many fallacies in that article. Again, it was later reported there are many fallacies. So many of my anesthesia colleagues, especially the civil hospital, they said, oh, we don't want to really wear the facial mask, or they will take off their facial mask down and keep talking. So I showed them this report and said that wearing a surgical mask reduces 40-fold the dispersal of bacteria into the OT atmosphere. And so it is a must now, and it has been proved now beyond doubt that every member who is in the operation theatre should wear the surgical mask all the time. Now coming to proper OT attire, that is the OT footwear, OT dress, that is a scrub suit, and cap and face mask. Now change of footwear and footwear covers. This change of footwear should be much prior to the semi-restricted area. So if you are having a small setup and only one operation theatre and a small room outside, you should remove the shoes outside the operation theatre on a stand. For surgical core team, usually you should have comfortable, breathable footwear, and it should have protection from splashes and blood which is spilling down on your feet. Best is, of course, original clogs, but you can have similar imitations, or you can use rubber or leather shoes which are breathable. Of footwear, and if there is chances of spillage, then you can use disposable footwear covers which can really protect you from the blood which is falling on your feet. Other OT staff can use any suitable soft OT slippers who are not coming in the core area of the surgery. They can use any suitable soft OT slippers. And most important thing is that these all footwear should be daily thoroughly cleaned with detergents or an antiseptic solution. This is many times not done. Otherwise, this footwear itself will carry bacteria into the operation theatre. Now, these are some of the original clogs or the imitations of the soft slippers. Now comes the changing from street clothes into the OT dress. Usually, there are changing rooms in even small or medium nursing homes, but they should be in the semi-restricted area, a bit away from the restricted area of the operation theatre. A proper OT scrub should have its efficacy of material used is very important, and it should be comfortably fitting, not a very tight fit. So you should have really OT dress for each person who is commonly working into the operation theatre. This OT dress should be definitely freshly laundered after every use for all staff. There are guidelines about proper donning and doffing. A doffing occurs if case of reuse in between cases, or if the person is going out of the operation theatre. And then strict compliance by all staff all the time is very, very important if you want to reduce the SSI. Now, White, Bailey and others have described the ideal material for OT dress as 100% spun-bound, non-woven polypropylene, which were all these things which we are using during the COVID times. The woven synthetic fiber, if at all it has to be used, it should be polyethylene, which is 1,000 times better than cotton in filtering the skin swamps, which are having 4 bacteria on an average on each. Cotton has a pore size of more than 80 microns and thus doesn't prevent the dispersal of skin swamps into the OT atmosphere. And so usually cotton dress is not recommended.
Sanjeev sir, 2 minutes remaining.
Yeah, 2 to 3 minutes. Yes, I'll finish. This is a non-woven dress which is usually disposable. It is not used as a scrub suit, but we usually use a polyethylene blend operation theatre dress specific for every person. Cap and face mask, as I said, must be worn by all the OT staff all the time. The material used, which in many operation theatres till now was a common practice of cloth caps and masks, but it has been now proved beyond doubt that cloth caps and masks should not be used. You should use disposable, non-woven polypropylene cap and masks, which are not very costly, and so definitely even small nursing homes can use them. The cap must cover all facial and scalp hair, while the mask must cover nose, mouth properly, and nasal metal strip should be there to press fit on the nasal breach. After COVID, many of us are using N95 masks, which are still better in filtering capacity. And double masks definitely are not recommended because the air does not, exhaled air does not cannot escape out. And so it comes out, it vents out from the sides and spoils the atmosphere. You can use a face shield if you want, if there is a space, splashing is expected, but it has to be sanitized before every use. Ideal way is first remove street footwear outside semi-restricted area, then come into the changing room. And they say that cap and mask is to be first worn. They say if you wear the OT scrub suit first, and then the skin swamps and the nasopharyngeal bacteria will fall on your OT scrub suit, and so they will again make them non-sterile. So you should first wear cap and mask, and then wear the OT scrub suit, followed by the OT footwear. And one more thing which I always see, that the face mask is either should be on all throughout the surgical process inside the operating theatre, or if it is taken, it should be completely off. If it is hanging, again, it can spoil the OT scrub suit. If in between the cases somebody has to go out, then it is best to change the dress, especially if it is soiled. If at all you cannot change other OT staff, they can wear full cover gown with full sleeve, which I had sold as a polypropylene thing. And strict compliance is very important. Restricting OT personnel and OT traffic, I think this has been discussed by Sandeep. And bad thing is that lock from inside. वो बॉबी का जो गाना है, अंदर से कोई बाहर ना आ सके, बाहर से कोई अंदर ना आ सके. If at all, whenever possible, just lock the door from inside, because we see so, even in big corporate hospital, so many people are unnecessarily going out, coming in, going out, coming in. That OT traffic, it has been proved by Dulles and all that the concentration of airborne bacteria is dependent on the number of persons. And so nobody should live and re-enter without reason. And if at all they are going out of the restricted area, they should wear the gown. Now coming to the hand hygiene and scrubbing by surgical team. Again, it was said that because we are wearing gloves, why we should really take so much care to scrub properly. It was found by various reports that 30% to 67% gloves are perforated during orthosurgery. So again, if there are bacteria on your hands, they will go directly into the surgical wound. So proper hand hygiene is very important. Goals are to remove the transient skin from the fingernails, hands and forearms, to reduce the resident microbial population to an irreducible minimum, and should have a cumulative and persistent microbiological activity lasting till the completion of the surgical procedure. Now, preparing for heart surgery, we know all fingernails should be trimmed, remove all ornaments like rings, bacteria, whatever. We have seen videos where it was shown that under the gloves, people were wearing rings. They can harbor bacteria like anything, so they have to be removed. There should not be any bruises or cuts on hands of the forearms. And first preliminary hand wash should be there with an antimicrobial soap, and then soft scrub for the subangular areas. Now, ideal antimicrobial solution for scrubbing. It should be non-irritating, possess a broad spectrum of antimicrobial properties. It should substantially reduce the transient microorganism present on the forearm and hands. It should be fast-acting and have persistent and cumulative activity. Usually, it is used in either disposable containers are the best. Otherwise, refilling steel containers should be cleaned nicely after every use before refilling. Most active scrub solution and their efficacy in the order as they are most ideal is the chlorhexidine gluconate, that is 4% chlorhexidine gluconate weight by volume is the ideal one, because it reduces about 99% bacteria with repeated applications, and it has a long-lasting residual effect. But most commonly what we use is the iodophos or the povidone iodine, which is 7.5% as a surgical scrub. It leads to the same reduction in initial reduction, but it has less residual effect with rapid regrowth. And it was sometimes found that at the end of a long surgery, if you remove the gloves, the bacterial colonies are more on the hand than before taking the surgical scrub. So really, povidone iodine and 7.5% should be discarded for chlorhexidine gluconate, but it is still most commonly used in our country. I think the color which it imparts, we know that it has been properly painted. That is the reason for years together we are using iodine. So our mindset is for the iodine. But now chlorhexidine gluconate is the most ideal. Other scrub solutions like triclosan and hexachlorophene are either not very effective or have toxic effects and have been given up. Antimicrobial soap, which is still used in many operation theater, but it is given up worldwide, and it should be only used first to remove the dirt and lint on the hands. What should be the ideal duration of the surgical scrubbing? Various reports suggest various things from 2 minutes to 10 minutes, but it actually depends on the speed of action of the scrub solution used. And for this chlorhexidine or the povidone iodine, it is about 2 to 3 minutes each step, and it is to be repeated 2 or 3 times. So this is the ideal way of surgical scrubbing. First scrub fingers to above the elbows for 2 minutes. Then use sterile water, AquaGuard or similar to wash off. Second scrub up to upper forearm for 2 minutes. And the final scrub is up to the hands and up to the mid forearm. My practice is that I don't wash off the last scrub because still we are not sure about the water which we are using. So I just keep that lather of the scrub on my hands and up to the mid forearm, and I enter into the operation theater and wipe off with sterile napkin after 1 to 2 minutes. This type of posters, please conclude. This type of posters can be there. Wearing surgical gowns, sterilium or after the wiping of scrub lather, double sterile disposable of first pair of gloves is worn now, and then wear the full length gown. Body exhaust if at all orthopedic surgeons are using, and sanitize protective goggles or face shield if needed, and after patient draping and before starting the surgery, the final pair of gloves is to be worn. These 3 things will be covered by Dr. So as I said, by following the world standards, are we actually increasing our cost of treatment with not so much change in the treatment outcome? Do these guidelines compel us? And so what Dr. Lalin mentioned, we should have our own operating room guidelines. And so this parallel question will be answered after that, that has the shift to the newer SOPs actually reduce surgical side effects? Because many small nursing homes say that we don't have really that much infection because the number of surgeries are less, number of people moving out and everything. So really whether the newer SOPs have reduced the things or which really require further research. But of course, there can be no compromise on OT protocol for all staff and teach them to treat OT as an operation table and not as operation theater. These are the things which I was talking with Dr. Gadegone. We can prepare this type of posters, and these will be pasted on the door of the operation theater. And so whenever somebody is entering, he will be really jolted or shocked that, oh, I am not wearing the OT sleepers. I am not wearing the face mask. I should not enter. Well, it definitely occurs in small and medium nursing homes. When you are not there, people will enter inside the OT for small things and come out without wearing anything. So this type of posters are very important. Thank you very much. I may have exceeded a bit, but I think this was the most important thing which we should learn and also teach our OT staff and paramedics for the thing. Thank you.
Yeah, thank you, Sanjeev Bhandari sir, for the great talk, lot of learning points. we can have 1 or 2 questions, and then we can move to Dr. Kiran Saoji sir. Yeah, Dhawal sir, please ask.
So Bhandari sir, on the SOPs, there are two things. Are there any standard guidelines for the theater size and barriering for nursing homes? And then secondly, what's your take on this disposable water repellent or waterproof stuff that we use? I find these are not really what they claim to be very often.
Which disposal? I didn't get it.
This waterproof, water repellent or disposable that we use, are they really what they claim to be? Typically,
because they are non-woven, sir. These polypropylene, either cap, mask, or the OT dress, or the now the gowns which you are wearing. If you use them, the skin squams cannot escape out of that. While if you are wearing a cotton dress, then it has got 80 micron pore size, and so the skin squams are somewhere 20-30 microns, and so they can come out of this cotton dress and contaminate the OT air. I think that is.
No, sir, my concern is for the surgeons. Like you are doing surgery that have a blood contamination. Most of these are not really waterproof or water repellent. If you think so, what's your recommendation for surgeon protection?
If anybody else can really tell about this, because water repellent, I am using a parachute gown, a gown which is having parachute cloth on the front, and so if something spills on my gown.
Dhawal, I can say,
yes,
if you are using any good gowns, like what I use is from Hilliard.
Yes.
Hilliard gowns, they are really, really good. I never get any seepage into my clothes ever, even after revision surgery or any surgery. And I think it's worth the money because you don't have any contamination, neither you sweat, it is breathable partly, not coming inside out or something like that. But I think it's worth it. And it's only hardly cost you 250 rupees if you buy in bulk. If I buy in bulk, it gives me 250 rupees. So I think 4 people for any major surgery, 1,000 rupees is hardly a point.
Sure.
But even the cloth gowns with a parachute cloth in front, if you are worried about the sweat coming out or the blood going inside, I think they can also, if they are properly autoclaved in a small setup, because people are using cotton gowns, and I really want to say that you should not use them. You should use either polyethylene, and then over that the parachute cloth on the front and on your upper limbs, then on your forearms and all, then that is really protective. Anything else, sir?
Okay, thank you, Sanjeev sir. And now we can move to Dr. Kiran Saoji sir. He will be talking on the preparation of the patient in the OT pre-induction and the preparation during the table and draping procedures. Yeah, Dr. Kiran Saoji sir.
I am sharing the screen. Am I audible?
Yes, sir. Audible and visible both. Please move to your first slide. Yes, sir.
Good morning, everybody. First of all, I am thankful to Dr. Gadegone, President, and Dr. Karne for giving me this opportunity. I am going to speak on preparation of the patient. Am I audible?
Yes, sir. Go ahead, sir.
Coming to the skin preparation, I have divided into 3 parts, that is pre-induction preparation, preparation on OT table, display and draping. Coming to the pre-induction preparation, patient should be hospitalized day prior to the surgery. Outside clothing should be discarded and clean hospital clothing is provided. Bathing morning and evening, day prior to the surgery with an antimicrobial soap with chlorhexidine gluconate bathing scrub is advised. Aim is to ensure the skin is clean before surgery. You should encourage the patient, if necessary, to have a shower with a soap, antimicrobial soap. A Cochrane review showed no clear evidence of benefit for preoperative showering or bathing with chlorhexidine gluconate over other wash product to reduce the infection. The simple soap bathing is also enough. Coming to the skin preparation of surgical site, aim is To have an operation site free from transient and resident microorganisms, dirt, and skin oil. To decrease the danger of infection from resident microorganisms. Antiseptic agents used available are alcohol, chlorhexidine, triclosan, and iodine contained agents, which helps in rapidly killing both resident and transient microorganisms, suppresses their regrowth till the surgical procedure. Skin preparation, that is mechanical cleansing. Prepare the skin with antiseptic solution which you prefer. Use sterile gauze sponge and don sterile gown and gloves while doing so. Scrub the skin in circular motion at least for 3 minutes. Start at incision point and move to the periphery. Discard the sponge after reaching the periphery and get new one and continue. Pads to collect excess preparation solution to prevent pooling of solution under the patient during the surgery. Coming to the concept of pressure and friction. See, pressure and friction increase the antimicrobial effect of an antiseptic. For example, alcohol applied without friction reduces the bacterial count by 1 to 1.2 log raised to 10 colony forming units compared with 1.9 to 3 log raised to 10 colony forming units when friction is used. That is from WHO guidelines. Coming to the antiseptic solutions which are available, that is chlorhexidine gluconate, which is available aqueous and alcohol. So aqueous base is ingredients in aqueous base ingredients are chlorhexidine gluconate and cetrimide solution. And in alcohol base you get 3M skin preparation which contains chlorhexidine gluconate and isopropyl alcohol. Then another alcohol preparation is aseptic LA. That is ingredients are chlorhexidine gluconate, isopropyl alcohol and cetrimide. You can get a iodophores also, that is povidone iodine. Again, it is an aqueous and alcohol base. Aqueous base contains the povidone iodine and non-ionic detergent. And alcohol base, that is 3M Duraprep, which contains proacrylics and isopropyl alcohol. Coming to the how you will select the solution. Choice of antiseptic skin preparation. There is alcohol-based solution of chlorhexidine, first choice unless contraindicated to surgical site in near to the mucous membrane. Then aqueous solution of chlorhexidine if surgical site is near to the mucous membrane. Alcohol-based solution of povidone iodine if chlorhexidine is contraindicated. And aqueous solution of povidone iodine if both alcohol-based and chlorhexidine is not suitable. From the literature, it is found that there is no evidence to favor the use of chlorhexidine over the povidone iodine solution. Another paper also concludes that chlorhexidine solution and povidone iodine solution combinations are equally effective as pre-operative skin antiseptic preparation in orthopedic implant surgery. But there is one reference from foot and ankle surgery which concludes that chlorhexidine isopropyl alcohol likely offers better skin decontamination before clean surgery than povidone iodine. There are different opinions. After the preparation, solution should remain wet on skin at least for 2 minutes and then dry the area with sterile sponge. After that, you paint the area with cutacept that contains isopropanol and benzalkonium. Or you can paint with the ramadine or betadine solution, that is 10% aqueous solution, either aqueous or alcohol solution. Coming to the hair removal, which causes breaks in the skin, which permit the entry and colonization of microorganisms, potential source of infection, should be done just before the surgery, but not in OT to minimize the contamination. Should be written in doctor's order. Technique: shaving, clipping, using cream. Clipping is preferable. Hair clippers cut the hair close to the skin. It is the preferred method of removing hair as they are associated with low risk of causing abrasions. Electric clippers with a disposable single patient use head are most effective method of removing the hairs. Specialized preparation area like axilla, groin, umbilicus should be thoroughly cleaned using the separate gauze prior to the skin scrub. Universal precaution, that is standard universal precaution. Precaution to protect against exposure must be taken when there is a potential exposure to the body fluids. It is assumed that all bodily fluids have potential to transmit disease. Coming to the display in the OT, there should be X-ray. You should have a display for the X-ray and display board, which will show name of the patient, age of the patient, surgeons and procedure, and etc. It is must. Then draping of the patient. Aim in draping is to isolate the surgical site from other parts of the body that have not been prepared, to isolate from non-sterile OT equipments and personnel. Draping of the patient is important step, should not be assigned to any experienced assistant. Haphazard draping results in exposure of unprepared area of the skin. In the foundation layer of the drapes, towel clips are placed through the skin to prevent the slipping of the drapes. Foundation drapes should be placed to overlap the prepared area of the skin at least 7.5 centimeters. A disposable drape, a one layer made of waterproof plastic should be used. Sterile stockinette is drawn proximally over the operative field. Large transparent plastic adhesive drapes, that is IOBAN, is wrapped over the entire operative field. Old incisions should be traced with the sterile marking pen before application of the plastic adhesive drape material. Double layer drape is preferred. 3 drapes can be placed over the endotracheal tube when you give a GA. Coming to the draping, this is the draping of the hip. After cleaning, this is the social drape, you can say. This is the first the foundation drape should be fixed properly. Are you able to see?
Yes, sir. Very clear.
This is the first layer of drape, head side. This is the draping for hip surgery. We will see now knee. This is for the knee surgery from head side. This is from the head side. 3 drapes and now for the anesthetist barrier. This is from the foot side for the knee surgery. This is last one.
Dr. Saoji, probably
Yes.
it is repeating the same thing.
No,
Can
no,
you
okay.
go ahead and
Yeah,
continue?
okay. This is
Who
last
is
one.
next, Girish?
So next is Dr. Vijay Ganbote.
Yeah. Can you stop the video, Dr. Saoji?
Yeah. I'll
To
stop the
next
video.
slide.
Just thank you very much. Hello. I'm thankful to Dr. Unmesh Mahajan for helping me for this video. Thank you very much.
Can you stop sharing the screen?
Yeah.
So is there any question? Then we can move to the next speaker.
We can ask Dr. Vijay to share his screen.
Dr. Vijay wants his presentation after one more presenter. So we can, so we can take the next presenter, Dr.
I can talk if I am ready.
Okay.
With talk.
Are you ready with your presentation, sir? You can share your screen.
Am I visible?
Yes, sir. Very clear. Please go ahead, sir.
Okay. I am very much thankful to the organizers for giving me an opportunity to talk on this very important topic, that is the management of anaphylactic shock in the operation theatre. Now, what is the anaphylaxis? Anaphylaxis is a potentially life-threatening systemic allergic reaction characterized by circulatory collapse, laryngeal stridor, bronchospasm associated with angioedema and the urticaria. There are so many causative factors for this, but the most important for us are the medicines or medications, especially the penicillin sulfas, even the vaccines, opioids, aspirin, non-steroidal anti-inflammatory drugs, even the local anesthetics can cause an anaphylactic shock. The others are latex, blood products, including plasma immunoglobulins and the whole blood. Idiopathic origin is also there sometimes, like the insect bites. Now, what is the basic pathophysiology? First, we will have to understand the pathophysiology basic, then only we'll be able to treat the patient properly. There is always a previous exposure to the allergen followed by an incubation period, which leads to the antibody formation. And when there is a re-exposure to the same allergen, it leads to the anaphylactic shock. The anaphylactic shock is usually due to the immunoglobulin-mediated allergic response from the mast cells and basophil granulocytes, which leads to the liberation of the prostaglandins, histamines, platelets activating factors, cytokinin, and chemokinin. Histamine plays the major role in the anaphylactic shock. There are so many high number of anaphylactic shock where there is no specific reason is found, and these type of reactions are called as pseudo-allergic reactions or the non-allergic reactions. This is a very important slide which shows you the most important signs and symptoms. There is a confusion and gradually the patient becomes unconscious. There is a presence of conjunctival injection. There is a flushing of the face, angioedema, which leads to the edema to the lips, tongue, and even the glottis and epiglottis. There is a presence of a laryngeal stridor because of the laryngeal edema. Then bronchial spasm will lead to the wheeze. There is a hypotension, and there is a urticaria or a skin rash all over the body, because of which a patient gets the itching. This itching is specifically there on the palm and on the foot and in the genitalia. There can be a gastric upset, and there can be a cardiac arrhythmias. Out of all these signs and symptoms, the most common is that 90% of the cases you will get the skin lesions, whereas 70% of the episodes there is a respiratory involvement is there, and in 45% of the episode you will find the involvement of gastrointestinal and the cardiovascular system. There are no specific laboratory tests to diagnose about the anaphylactic shock, but it has been observed that there is a raised serum level of histamine and tryptase, and these levels remain high even up to the 4 to 6 hours. So even after the subsidence of this anaphylactic reaction after treatment, you can do the blood test for these two things, that is the histamine and tryptase. Now, what to do in case of the anaphylactic reaction? Once there is anaphylaxis, you notice it. First, you stop the thing which is causing this anaphylaxis. That is, if you are giving the blood, or if you are giving the IV fluids, or you are giving the antibiotic, you have to stop that allergen. Then do the detailed physical examination. In the detailed physical examination, depends upon the signs and symptoms what you observe. This anaphylactic reaction is categorized into 4 grades. That is from grade 1 to grade 4, depends upon the systems involved and the signs and symptoms which you are observing. First thing is the positioning. If the patient is unconscious, then the patient should be placed in the recovery position as shown in this diagram. If the patient is having hypovolemia, or there is a patient because of the peripheral dilatation and patient is having hypotension, you have to do the leg raising. The tendon bar position is very much preferred. If the patient is having the upper respiratory tract involvement, then the patient should be kept in the sitting position or semi-sitting position. The treatment, this treatment protocol is very important, and you have to carry out the treatment in the same chronological order. First of is the most important drug is the adrenaline, second is oxygen, third is histamine, and then on corticosteroids, fluid replacements, vasopressors, and bronchodilators. First, I will try to discuss about the adrenaline, the most important drug in the acute therapy of anaphylaxis. Functionally, it antagonizes all the important pathomechanisms of anaphylaxis by causing a vasoconstriction, bronchodilator, edema reduction, positive inotropic effect on the heart. Adrenaline can be given intramuscular, subcutaneous, or the intravenous route. Out of this, subcutaneous route is more or less nowadays not used, but intravenous administration shows the fastest onset of the action. In the patients where the resuscitation is not required, here you can try intramuscular injection of 0.3 to 0.5 ml of 1 in 1000 adrenaline on the upper and outer aspect of the thigh. You watch for the regression of the signs and symptoms. If you find that it is not responding, then you can repeat the same injection after every 5 to 10 minutes. But when the patient is unstable or during the resuscitation, in this situation, you have to give injection intravenously. For this, dilution of 1 milligram of adrenaline in 10 ml of normal saline, out of this solution, 0.1 milligram may be administered. Continuous monitoring of the circulatory parameter is must. A continuous infusion of 0.5 to 1 microgram per kg per minute is equally effective And this can be given through the infusion pump with the continuous monitoring of the pulse and blood pressure and cardiac position. When there is an increase in the cardiac output, it causes the increase in the oxygen demand, and this leads to the anemia. So in the patients with coronary heart disease, the intravenous administration of the adrenaline may lead to the myocardial infarction. So you have to be very cautious about this. The indication should, however, be carefully considered in the patients with pre-existing heart disease. Adrenaline can also be given by inhalation. You can give it through the mask, or you can do administer it by inhalation through the nebulizers. Now, the second important thing which you have to do is the oxygenation. In the case of cardiovascular and the pulmonary reaction, immediate supply of the high flow of the oxygen via oxygen mask with the reservoir bag is recommended. Administration of the high flow of 100% oxygen is recommended through the laryngeal mask or the laryngeal tube. In some situations, you will have to put the endotracheal tube for a proper oxygenation. Volume substitute, because there is a hypovolemia, because of there is a vasodilation. So you have to replace it by the IV fluids. The IV fluid replacement can be done by the crystalloids and the colloids. It is supposed that you have to do the fast infusion of, or even up to the 2 to 3 liters of crystalloids is there. But if you find that patient is getting overload, or if you find that the patient, the blood pressure is not coming up, or it is not holding the blood pressure, in that situation, you will have to administer the colloid. And there are n numbers of colloid which are available, but you have to be very cautious when you are giving the solutions like gelatin and dextran or hemacil. Here, the histamine liberating potential is there in this solution, which can again trigger the anaphylaxis. The safest and most properly now used is the starch. There is a hydroxyethyl starch, which is most commonly used as a colloid in the treatment anaphylactic shock. These are the examples or names of some crystalloids and colloids. In the crystalloids, you use usually normal saline, ringer lactate, 5% dextrose. In colloids, you can use the human albumin, gelatin, dextran, and hydroxyethyl starch, that is the starch, which is more popular and which is more commonly used. Other vasoactive substances, when you find that even you are giving the so much of infusion and putting the patient on crystalloids or colloid, if you find that the blood pressure is not coming up or it is not holding, then in that situation, you have to use the vasopressor drugs like dopamine, noradrenaline, and vasopressin. They are given through the microdrip or through the infusion pulse, and the continuous monitoring of the vital signs should be done. Now, what is the role of H1 receptor antagonist? Compared to the adrenaline, histamine shows the very slow action, but antihistaminic should be given early in or in anaphylactic shock. But it has to be remembered that the first drug of choice is always the adrenaline. Administer 10 milligram of phenylephrine malate intramuscularly, slowly IV, along with the initial resuscitation of the patient. But the effect of this antihistamines on other parameters, that circulatory and respiratory parameters, it is very less. The corticosteroid, the use of the corticosteroid is done, but it doesn't show much helpful in the management of the anaphylactic shock. Only thing it improves or it enhances the tissue response to the drugs which you are using. But this drug is helpful when there is a biphasic reaction. The biphasic reaction means once there is a subsidence of the first attack, patient becomes normal, but after 4 to 6 hours, you find that the patient is again getting similar signs and symptoms of the anaphylactic reaction. So to prevent this type of biphasic reaction, you can give the hydrocortisone, that is a 200 milligram of the hydrocortisone IV, and it should be repeated after every 4 to 6 hours. Now we will discuss the management of anaphylactic shock with the involvement of various systems. Specifically, now we will discuss about the cardiac or the circulatory system. When there is a cardiac and circulatory shock, you have to do the cardiopulmonary resuscitation by doing a cardiac massage, and if there is a ventricular fibrillation, you have to defibrillate the patient. Intravenous catheter is mandatory. Intravenous administration of adrenaline is the substance of choice in this situation. First, secure the airway for sufficient oxygenation. Endotracheal intubation of the laryngeal mass or the laryngeal tube is most important thing you have to do. In the rare conditions, you may have to do a tracheostomy. But when there is a anaphylaxis with the obstruction to the upper airway, the typical signs of the upper airway obstruction is there is a presence of the stridor. This you can notice from the edema on the lip, the edema on the tongue, and there is a uvula is also very much edematous. In this situation, these are the very life-threatening situation which can lead to hypoxia. So in this life-threatening situation, first you can use or you should choose intramuscular injection of the adrenaline. And along with that, you have to give oxygenation. Adrenaline inhalation is also indicated in some time. In difficult situation where it's not possible to give the oxygenation, then to the nasopharyngeal or the laryngeal tube, then you have in emergency you have to do sometimes the tracheostomy. The anaphylaxis with the predominant bronchial obstruction. The bronchial symptoms, the most common symptoms is a severe anaphylaxis. In potentially life-threatening situation, the intramuscular injection of the adrenaline is very much indicated.
Vivek sir, 2 minutes.
Yes. Anaphylaxis with the predominantly abdominal symptoms, when there is a presence of the nausea, vomiting, and all this. Here, these symptoms can be treated with the drug like the metoclopramide and the ondansetron. And if the anaphylaxis is predominantly with the skin infestation, when there is a skin infestation, as I have explained, there is a rash, itching, and all that. First thing you have to do the set up the IV line, and then you can give the anti-allergic substances like dimethylidine or the glucocorticoids can also be given. The intravenous injection of chlorpheniramine malate, promethazine hydrochloride injection should be also given when there is the skin manifestations. Now the take-home message is anaphylaxis is defined as a serious allergic reaction. Prompt recognition and treatment is critical. Adrenaline is a drug of choice in all this management of anaphylactic reaction. Thank you very much.
Yeah, thank you, Vivek sir. We can have 2 or 3 questions and then we can move to Dr. Vijay Ganbote for the next talk. Vivek sir, to avoid or to manage the anaphylactic shock after one first dose of the antibiotic injections, when the patient has been treated in ward, what are the basic things to do?
I couldn't get your question.
Sir, if anybody gets the anaphylactic shock after the first antibiotic injection to the new admitted patient in the ward, what are the things in the priority to do in the nursing home?
If you get a reaction with the antibiotic, you want to say?
Yes, sir.
Then if you get a reaction to the antibiotic, first thing you have to, if you are giving it slowly with the IV and you find that the patient is delivering the signs and symptoms, first thing you have to do is to stop giving that IV injection. Second, most important thing, you have to do an injection of adrenaline. Because there are people who mostly they say that give hydrocortisone, give Avil or Finargan. No, you have to give first the adrenaline. Take 1 cc of adrenaline, dilute it into the 10 cc syringes. Out of that, you can give only 0.3 to 0.5 ml intramuscularly and see for the response.
So I think recognizing the symptoms are very important. So we should have at least one trained staff or the RMO doctor who is at least reasonably trained to identifying the anaphylaxis reaction.
So that's why I have shown you that slide, very important slide, which shows you there is drowsiness, there is a confusion, patient is becoming gradually unconscious, or there is a hypotension, hypoxia, and most important is the upper respiratory signs, that is a stridor is present, he gets a choking sensation, difficulty in breathing, or skin rashes. As soon as you notice this thing, you should diagnose it as an anaphylactic reaction and start treating this as early as possible. And the first drug of choice in that, the first drug of choice is the adrenaline. Many times you observe in your operation theater also, you start blood transfusion, and after some time the patient starts getting the rash, or there is a itching when the patient is conscious. He says that I'm getting itching here and there and all that. So you should, these are the very alarming signs which you have to be very cautious and keep on watch.
That's what many times the senior people suggest, that all newer drugs should be given in the morning hours. So when everybody is active, doctor is there in the OPD, and there is a sufficient staff. Also, keeping the emergency drug box in casualty wardrooms OT is must. Yeah, thank you, sir. And now we can move to Dr. Vijay Ganbote, sir. Are you ready, sir?
Yes.
Yeah, please share your screen. Thank you, Vivek, sir. And we can have the next talk on management of the anesthetist desk by Dr. Vijay Ganbote, sir, from
Is it loaded now?
Yes, sir.
Okay. Good afternoon, friends. This is Dr. Vijay Ganbote from Ahmednagar, and I am dealing with the topic anesthesia desk. Firstly, I would like to thank the Maharashtra Orthopaedic Association for giving me this opportunity to communicate with you all. The anesthesiologist, and the anesthesia desk forms the quintessential part of any surgical endeavor. And as the theme of this webinar goes, I will like to say, if OT is the temple, then anesthesia desk is not less than the sanctum sanctorum of this temple. But what actually the workplace used for giving anesthesia to the patient to be operated upon in the operation theater by a qualified anesthesiologist. This can briefly describe what it means by the anesthesia desk. So it involves 4 distinct components: the person, that is the anesthesiologist, the equipments, the drugs, and the processes. Anesthesiologist, the person. This is the main pillar of the anesthesia desk. But it is to be understood that an anesthesiologist must be a well-qualified anesthesiologist. That is, having a postgraduate diploma or degree. That is, diploma anesthesia, MD anesthesia, DNB anesthesia, as well as there are fellowships in anesthesia super specialty like neuroanesthesia, cardiac anesthesia, transplant anesthesia, and critical care, and so forth. The other most important part of this person is the trained assistant or staff in the operation theater. However expert the anesthesiologist may be, he requires a trained assistant during his work in the operation theater. This assistant is from the team of the operation theater and employee of the hospital. Then the equipments required for the anesthesia desk. For general anesthesia, the most important are, as is known, Boyle's apparatus or machine. Boyle's apparatus has formed the most important part of the anesthesia desk from ages, and it has evolved over the period of years. Then there are multipara monitors, which are showing the pulse oximeter, SpO2, pulse rate, ECG, then NIBP, EtCO2, temperature, and such things. These multipara monitors have increased the safety of the patient and the surgery manifold. Then there are ventilators. When general anesthesia given to the patient is put on positive pressure ventilation, and for that ventilators are required. But these are not separate ventilators, but the part of the workstations. Then comes the modern anesthesia workstation. These are the state-of-the-art machines which help in delivering the general anesthesia to the patient. It helps in delivering the precise amount of anesthesia gases, that is oxygen, nitrous oxide, as well as anesthesia vapors. It not only helps in the safety of the patient, but also reduces the consumption of anesthetic gases and the anesthetic vapors. So overall, minimizing the cost of the anesthesia. Then there are circuits used for general anesthesia. The Bain circuit, which is an open type of circuit, a closed circuit, then the JR circuit used for pediatric anesthesia, O2 mask, nasal cannula, so on and so forth. Then you require gas connections, because most of the modern OTs now have central O2 supply, as well as central nitrous oxide or central air supply. So these central connections or spare cylinders and vaporizers need to be kept ready. Then there are equipments needed for the regional anesthesia equipments, because in orthopedic surgery, most of the cases, especially the lower limb cases, are done under regional anesthesia, and upper limb cases are done under the blocks, various blocks. So what we need is spinal needles of the numbers 23, 25, 26 or 27. As small bore needles like 26 or 27 are available, they have reduced the incidence of post-spinal headache. Then epidural sets number 16 and number 18. So those patients who are compromised in cardiopulmonary function, they can be safely done under the epidural anesthesia. So these need to be kept ready in the anesthesia desk. Then PNS set, that is peripheral nerve stimulator with needles. This has made the various regional blocks very safe and precise, so that the rate of complication has reduced and effective and anesthesia can be given to the patient. And the latest in this series is USG machines to give the USG guided blocks. Even though small to medium size hospitals may not have these, but big hospitals do have these USG machines which are used to give the regional blocks. Then the most important part of the equipment is airway equipments. The laryngoscope set with all size of curved, that is Macintosh, and straight, that is McGill's blades, the spare batteries, spare bulbs. These need to be kept ready and to be taken care that the batteries are always full and bulbs are working. And then the endotracheal tubes of all sizes, starting from 2.5 and above, all the size cuff and non-cuff, and also flexometallic tubes, because in pediatric cases, non-cuff tubes are required. So we have to keep the whole range of the tubes available at the anesthesia desk. Then also there are newer airway devices. Those are called as supraglottic devices. That is LMA, that is laryngeal mask airway, IGL, etc. Then because of the advancement in the technology, newer kind of laryngoscopes are being available. These are video laryngoscopes, which are very useful in the difficult intubation scenarios. Because if the patient has difficult airway, it is very difficult to visualize the vocal cords and intubate. In these scenarios, video laryngoscopes are very helpful. Then comes the fiber optic laryngoscope. These fiber optic laryngoscopes are also required in the difficult airway scenarios where patient has to be intubated in awake condition and then induced. Then there has to be ready a tracheostomy set, because sometimes even preparing all these above the airway equipments, it becomes difficult to either ventilate or intubate the patient. In these scenarios, an emergency tracheostomy is a must to save the life of the patient. So tracheostomy set should be there in the anesthesia desk. Then there are other supporting instruments of the airways, like McGill's forceps, various numbers of stylates and bougies that to be kept ready. Then there are emergency equipments, because OT is a very happening place and most of the complications can occur in the OT. So we have to keep ready the following equipments which are required in these emergencies. The most important is defibrillator. If for any reason the patient get cardiac arrest, we need to defibrillate the patient immediately. So it is not only important to save the life of the patient, but it is also very much mandatory in the medical legal parlance, because non-availability of defibrillator in such scenarios can make the liability on the behalf of the hospital, and that can be very difficult. So defibrillator, even though it is looks like costly equipment, it has to be there, and in the long run, it will save the cost only. Then the crash cart. All these emergency equipments and emergency drugs has to be properly arranged in the crash cart, and one fully loaded crash cart must be present in the operation theater as a part of the anesthesia desk. Then comes the suction machine with catheters. Suction machine is very important because in the patients where you need to give the general anesthesia, or in any case, because in intraoperative or immediate postoperative period, the chances of postoperative nausea and vomiting are there. So suction machine is a must where you can use in such scenarios, and you can prevent the compromise of the airway. Then other equipment like central line catheters and facilities for arterial line catheterization has to be there, because most of the patients in the orthopedic scenario are old age patients with different kinds of comorbidities. So to give safe anesthesia in these kind of patients, we have to keep these kinds of equipments ready as a part of anesthesia desk. And then comes the Riles tubes. Then there need to be kept ready the supportive things which are part of this OT scenario, like IV stand. This may sound like ridiculous, but especially in the small operation theaters or small setups, these things are mostly overlooked. So this has to be kept in mind, and this thing to be kept ready. That is IV stand, intracath or vena cava of all sizes, IV sets, blood sets, then three-way or extension tubings. Because most of the times the access to the intracath is reduced because of the particular position of the patient. So these things should be kept ready. Then arm pads for children, armrest. Armrest is a very important because without compromising the position of the patient, anesthetist gets access to the intracath for giving various kinds of drugs, and which is very overlooked in this small setup. Then OT table must be having head low and head up control so as to control the level of anesthesia, especially in spinal and epidural anesthesia. Then a pillow, then head ring and bite blocks. These are needed to maintain the airway of the patient and during giving general anesthesia. So they should be kept ready. Then patient warming system, because most of the OTs now are modular OTs with central flow and central AC. So the environment in the OT is quite cold, and patient body temperature, especially under general anesthesia, cannot be maintained. So in these scenarios, we need to keep the patient warm. So patient warming system as well as fluid warming systems must be kept ready in the setup. If in the small setups, even extra blankets, sterile blankets can be, or sterile towels can be made available to achieve this purpose. Then rapid infusion system. Whenever the patient needs to be infused with blood or colloids or other blood products rapidly, the rapid infusion system must be kept ready as a part of the OT scenario. Then a separate dustbin, sharp bin, and ampoule cutter must be made available at the anesthesia desk. It not only increases the comfort of the anesthetist working in that scenario, it also helps in proper disposal of the things. Then all kinds of paper record forms must be kept ready at the anesthesia desk, starting from pre-anesthesia checkup, the anesthesia consent, the intraoperative record, and postoperative record.
Sir, 2 minutes remaining.
Yes. Then comes the drugs. Drugs are the mainstay of anesthesia, which includes induction agents, that is intravenous agents like propofol, ketamine, etomidate, or dexmedetomidine, volatile anesthetic agents like halothane, isoflurane, sevoflurane, muscle relaxants like vecuronium, atra or cis-atracuronium, rocuronium, reversal agent like neostigmine, myopyrrolate, and pre-medication agents like opioids, pentazocine, or newer drugs available, which are like nalbuphine, fentanyl, buterphenol, then sedative hypnotics like midazolam and diazepam, antacids and antiemetics like pantoprazole, ranitidine, ondansetron, pyranam, and their other derivatives. analgesics like paracetamol, diclofenac, and tramadol, etc. Then the drug required for the regional anesthesia. For spinal anesthesia, lignocaine heavy 5%, bupivacaine heavy 0.5%, ropivacaine heavy. Then lignocaine in all of its varieties like 2%, 4%, 10%. Then viscous, spray, jelly, etc. required during the various phases of the anesthesia. Then bupivacaine 0.5% vial required for the epidural anesthesia, and injection mepentramine and ephedrine required to correct the hypotension during the spinal or epidural anesthesia. Then comes the emergency drugs like atropine, adrenaline, dopamine, dobutamine, nitroglycerin, then xylocard, labetalol, metoprolol, furosemide, soda bicarb, calcium gluconate, Kesol, aminophylline. These all drugs needs to be kept ready in the operation theater as a part of anesthesia desk. They have to be checked for their expiry date periodically, and in sufficient stock has to be maintained in the anesthesia desk. And last but not the least, the process during the anesthesia. The most important is pre-operative patient checklist. When your patient comes to the operation theater, it has to accompany the checklist, which has to be properly followed, like pre-anesthesia checkup done or not, patient is nil by mouth or not, for how much period, because for clear fluids, you require at least 2 hours of NBM, for non-clear fluids, 4 hours, and for solid fluids, 6 hours. Then a separate anesthesia consent has to be taken and maintained. Then removables, if any, with the patient like dentures or any ornament, they have to be removed. Then current medication, if any, and current known allergies, any drug allergies if the patient is having. This all has to be checked with the checklist. Then the equipments, the boils machine or the workstation and the airway equipments has to be checked before starting the case. So everything is properly placed or not. Then checklist for drugs, various drugs, and the labels have to be provided to the syringes for every drug, so that the mishaps by wrong drug or wrong injection are avoided. Then record keeping. As I said earlier, various kinds of record and blank forms must be kept available at the anesthesia desk so as to the record can be maintained properly. And last but not the least, the recovery. Even though these OTs, modern or in big hospitals, their recovery room is part and parcel of this operation theater complex. So there has to be a dedicated recovery room where monitoring facilities and resuscitation facilities, including oxygen, has to be kept available. Then, as we know, most of the hospitals are accredited with NABH. So it is mandatory that code blue must be process must be there, and it is to be followed. So all the staff working in the operation theater must be trained in resuscitation protocols. These are COLS, that is compression only life support, basic cardiac life support, and advanced cardiac life support. The various these program courses has been developed by the Indian Resuscitation Council, and you can take help of the your anesthesiologist to train all the staff for these protocols. Thank you.
Yeah, thank you, Vijay sir. Any questions? Yes, so next we have Dr. Abhijeet Wahegaonkar. He has a pre-recorded talk. Unfortunately, he is not physically available. So with the due permission of Dr. Sangeet sir, can I move to his pre-recorded and can I start?
He has logged in already. Abhijeet, you are there?
Yes, sir, I am, but I'm in the GBM, sir, unfortunately. Okay. So I request you to please play the video.
Right. You would be there for question answers?
Yes, I am around. Fine. I am around. Thank you. Thank you.
Girish, can you play his video?
Sure, sir.
Good morning, everyone. My name is Abhijeet Wahegaonkar, and at the outset, I would like to thank the President of the Maharashtra Orthopaedic Association, Professor Gadegone.
Is this audible and visible? Sir?
And the
yes. Everything is good.
Team and the brain behind the MOA Veterans Forum. My task today is to talk about the care of surgical instruments, which is ever so important in our day-to-day practice. So proper care and handling of our instruments is key to the longevity of the surgical instruments. And we tend to use stainless steel instruments more often than not. And these instruments especially require proper care to maintain their properties and to prevent any wear and tear or rust of these instruments. And even though stainless steel instruments are viewed as the best material, one can't assume that they are entirely corrosion resistant. There is improvement in the metallurgy, there is improvement in the material sciences, and we are getting better and better instruments. However, there is no there is no substitute for proper care and to wash and store them and autoclave them properly. And this process of cleaning and sanitization is complex and is very challenging and demanding, and we need to be familiar with the recent advancements to improve the shelf life and the longevity of our instrument. This is a very important investment we make, so we need to be extra careful, especially when you're using high-end or expensive instruments. So the steps in the care of instruments obviously begin with cleaning the instruments, and the process of cleaning soil instruments is ever so important, and this should be done as soon as possible by using manual or mechanical methods. And quick cleaning basically removes blood clots and can minimize instrument staining, corrosion, or pitting. Mechanical cleaning is a safer practice for staff and a more effective process over manual cleaning. Therefore, whenever possible, mechanically clean the instruments using a neutral pH detergent with warm water and a soft brush. Cleaning can be performed manually in the washing area outside the operation theater with tap water, followed by drying the instruments using compressed air. And then these instruments are transferred to the CST for further processing. So if you do have a provision for compressed air being blown onto the instruments, that can help a lot in the process of cleaning the instruments. Then comes the process of cleaning the instruments in the CSD. So the initial cleaning is done just outside the operation theater, and cleaning in the CSD involves these three steps. The instruments are washed under running water, and then ultrasonic cleaning is done, and then repeat washing under running tap water for about 5 minutes to dislodge any residual clots or any such problems. Now, ultrasonic cleaning is performed by using a multi-enzyme solution such as that which is available from different kind of companies here. I have shown the one that is available from 3M. The solution is changed daily, and do not overload your ultrasound cleaning machine. The usual cycle will run approximately 15 minutes depending upon the load. So as you can see, the instruments are placed in the machine in a water bath, and then the multi-enzyme is added and the machine is switched on, and that will complete the process of ultrasound cleaning. After ultrasound cleaning, the instruments are washed under tap water and then prepared for mechanical washing again. If there is a hollow instrument that can be cleaned, and then you can use compressed air to further dry the instruments and clean them thoroughly. We have different instrument washers that are available commercially. They can also be used. The instruments can be placed in the different trays, and then those trays are placed in the machine, and then they are washed and rinsed. So this increases the productivity. Multiple instruments can be cleaned at the same time safely and effectively. It reduces the risk of injury to the personnel, and they can also have high temperature or thermal disinfection at the same time. So this is again a very effective way of cleaning the instruments. Each instrument then should be inspected thoroughly to kind of watch for any corrosion and wear and tear. Never ever sterilize dirty instrument. That is key to having a long shelf life. In addition to each check, the instrument is checked for proper function, and any lubrication can be performed using different spray lubes that are available, especially at the hinges, so that the instruments function properly. I'm sure very many of us have experienced very tight needle holders or hemostats, and that can really be annoying during surgery. After the instruments are cleaned, they are prepared for packaging and prior to sterilization. So these instruments are arranged in a tray systematically with proper cushioning so as to avoid any damage to the sharp instruments. The tips of the sharp instruments are covered by silicone rubber, and they're kept in a separate tray so as to minimize any damage to these instruments. The packaging can be done in a sterilization pouch or a wrap or a container as shown in the slide. And these are usually performed using FDA approved products. And then for quality assurance, or to be sure that we have done the right job, we use a chemical indicator inside each pouch prior to sterilization. And this sterilization indicator tape should be used to secure the wrapper so that it serves to secure the wrapper for sterilization, as well as to give us the surety or the adequacy of the sterilization process. The sterilization process, again, is also very, very important, and we'll have talks on this in detail, but suffice it to say that heavier wraps are used and they are placed on the lowest shelf of the sterilizing machine, whereas lighter pouches are kept on top or on the edge. And this enables the moisture to drain out without wetting other items in the load. We take proper precautions to identify the load, to set the timers, to complete the cycle, and then sterilize our instruments. The storage and delivery should also be very meticulously followed. Sterile items should be stored in a manner that reduces the potential for contamination, and the shelf life of sterile items is event related and depends on the quality of packaging material, storage conditions, and the amount of handling. So minimize the handling of sterilized instruments or implants that are not in constant use so as to maximize their shelf life. Quality assurance is performed in a physical, chemical, and biological manner. And then this is basically routinely verified using these three types of indicators. So, I'm sorry, the 6 proper care and handling tips for your surgical instruments in summary are as listed on this slide. We immediately clean the instruments and dry the instruments after the surgery or after they have been used. The instruments should be used for their intended purpose only. Do not use a hemostat or a needle holder to bend K wires, for example, because that will damage the ends of or the tips of the instrument. So please use them for the intended purpose only. Do not place the instruments in saline or any other harsh solutions because they will corrode and they will cause rusting of these instruments. Use a soft brush for manual cleaning with kind of low neutral pH cleaning solutions. Lubricate all instruments that have any metal on metal actions before autoclaving so as to have proper functioning of those instruments. And ultrasonic cleaning is one of the most effective methods of cleaning these instruments. So with that, I thank you for your attention and for the opportunity to present in this wonderful webinar.
Yeah, thank you, Dr. Abhijeet Wahegaonkar, sir, for covering the topic on time and putting the practical tips of how to handle the surgical instruments. Sir, if you are available, we can have some questions.
Yes, sir. I'm available, sir. Thank you.
So may I ask the other faculties, you can bring some questions before we move to the other presenter, Dr. Sanjay Dhurjad.
So, can I ask a question?
Yes, sir.
Please. So, many places, and at times we have to use a double linen wrap for the instruments. Do they get a problem with this linen wraps, the instruments? And second question, if the instrument is very tight or jammed, what is the best enzyme cleaner you would recommend?
So, sir, there are commercially available. I'll take the second question first. There are commercially available enzyme lubricants, and they are spray kind of enzyme lubricants that are the best. I'm not sure of the components or the ingredients of these lubricants. They're commercially available, and they should be used every time that we clean the instruments and before we store them. The other question about the use of linen is absolutely valid and absolutely viable. There are so many centers wherein all these, fancy or very advanced systems of autoclaving and storage may not be available. However, I think it is fundamental that we use linen that is not perforated or torn, or the quality of the cloth should not be kind of inferior. So if you have good linen and if you have proper packaging and storing, that also is a good enough way of autoclaving the instruments. I hope that answers your question, sir.
Can I ask one question?
Yes, sir.
So what do you suggest for cleaning these cannulated drill bits, small cannulated drill bits?
Right. So the same steps, but I think it's best to use compressed air through the catheter. That's exactly what I said. If there is a lumen in the instrument, using compressed air to dry the lumen is very effective. However, there are also ultrasound washers. There are these pressure injection systems that can be used to dislodge any clots. Even manual cleaning can be done with fine brushes or using a trocar or an obturator through the cannulated instruments to clean them up.
Kiran sir. Kiran sir, please unmute yourself and ask the question. Okay, so I think it is freezed. So thank you, Abhijeet sir. And now we can move to the other presenter, Dr. Sanjay sir, the categorization and the disposal of the biomedical waste.
Thank you.
So, thank you very much. Can I share my screen?
Yes, sir.
Audible and visible as well?
Yes, sir. Audible and visible. Please share, start your presentation. Your presentation is not visible on, your first screen is not visible on screen.
Okay. Now?
Still it is like in the documents, you're opening the BMC management PPT.
Okay. Just a minute. I'll share it again. Okay.
Yes, sir.
Okay.
Yeah, now it is visible.
So thank you very much. Thank you everybody, and special thanks to special thanks to the President MOI, Dr. Wasudeo, who has entrusted me and is invited me to give a talk on what you can say a neglected but a very important topic. And my topic is categorization and disposal of biomedical waste. And what it can be summarized as the management of a biomedical waste. And we see a lot of pictures like this. Previously, we used to see in and around any hospital. And I think this is a big blunder that we are doing. Because first we will define what a biomedical waste is. It means any solid or liquid waste, including its container, and any intermediate product which is generated during the diagnosis, treatment, or immunization of human beings or animals, or research activities pertaining thereto, or in the production or testing of the biological or in the health camps. So any waste material which is generated in the hospital or in the laboratory can be termed as biomedical waste. And why is it important to know about the disposal or the management of biomedical waste is that the biomedical waste poses hazard due to two principal reasons. The first one is its infectivity and the other one is its toxicity. Although 75 to 90% of the material is non-hazardous or general waste, but the remaining 10 to 15% of the material which is derived as waste from the hospitals is hazardous to human beings or animals or to the nature. So what I feel personally is that we as doctors practicing in this society, we are not only responsible for the health of our patients, but we are also responsible for the health of the general people or the public at large. So that's why it is our primary responsibility as hospital owners or medical practitioners that we take due care of the hazardous effects of the waste that we produce through our practice and through our daily activities. So let's first see what types of medical waste that we generate. The first is the human anatomical waste like tissues, organs, and body parts. In case of veterinary hospitals, animal waste and animal body parts is one thing that can be produced as waste. Microbiology and biotechnological wastes. Waste like sharps, needles, syringes, scalpels, and broken glasses can be also part of the waste material. Discarded medicines and cytotoxic drugs. Soiled waste such as dressings, bandages, plaster casts, then material contaminated with bloods, tubes, and catheters. So that can be a part of the waste. Liquid waste from any of the infected areas is hazardous. And the methods which we used for disposal of waste, like incineration, ash and other chemical waste, is also a part of the waste material. And WHO has classified all these waste materials into 9 different categories. The first category is the general waste, which is not at a risk to the human beings, but material like office papers, wrappers, kitchen waste, and general sweeping material is a part of first category, that is a general waste. Then pathological waste, category number 2, which is human tissues or fluids that is being tested and thrown away in the dustbins, like body parts, then blood or body fluids, etc. They form the pathological waste. Sharp objects like needles, scalpels, knives, and blades, they form the third category of waste. Then the fourth category consists of infectious waste. That's the material which may transmit bacterial, viral, or parasitical diseases to human beings and to the people around. Waste which is suspected to contain pathogens like lab cultures, tissues, swabs, bandages, dressing material, etc. They are very much hazardous to the public. And category number 5 is the chemical waste. Chemicals used for laboratory material, that is the lab reagents, disinfectants, what we use for cleaning material, film developers, which was used previously, but now it has not been used because we have now the digital developers. Then sanitary cleaners, which we normally use for hospitals and household things, they also the chemical and which is hazardous when it flows out into the drainage and it mixes with the general water bodies around us. Radioactive waste, that is the unused liquids from radiotherapy or lab research and contaminated glassware of all those material used for radiation purpose. They form the 6th category of biomedical waste. The 7th one is the pharmaceutical waste, like unused or useless drugs, chemicals, which are expired or outdated medicines and chemicals. They form the 7th category. Pressurized containers, they also form a big chunk of waste material, biomedical waste, what we use in disposable cans or cylinders, like gas cylinders, aerosols, the sprays which we use in the hospitals. They are categorized as 8th section. And the final one is the 9th category is genotoxic waste, that is waste from cancer therapy like cytotoxic drugs and chemotherapy drugs, which if it is mixed with if it goes unnoticed, it can cause a lot of harm to the general public and the nature around us. The segregation is the first step in the management of the biomedical waste, where you can say that segregation refers to the basic separation of different categories of waste generated at the source, and thereby reducing the risk as well as cost of handling of the disposal of biomedical waste. Segregation is the most crucial step in biomedical waste management, because effective segregation alone can ensure effective biomedical waste management. How does it work? How does segregation work? It reduces the amount of waste needs special handling and treatment. Effective segregation process prevents the mixture of biomedical waste like sharps with the general municipal waste, prevents illegal reuse of certain components of biomedical waste like used syringes, needles, and other plastic material or other disposable material what we use and throw it once. So if it is segregated properly, it reduces the illegal reuse of all those materials, provides an opportunity for recycling certain components of medical waste like plastics after proper use and thorough disinfection. Materials like plastic and papers can be reused and recycled once again. Then recycled plastic material can be used for non-food grade applications, where the plastic can be melted down and again reused in industries where the plastics can be used as containers, but not in the food industries. Of the general waste, the biodegradable waste can be composted within the hospital premises and can be used for gardening purposes. So if you have a dumping ground, especially if the hospital setup is a bigger one, and they have their own STP plants and disposal plants. So all those biodegradable material can be composted and reused again. Recycling is a good environmental practice which can also double as a revenue generating activity, and it reduces the cost of treatment and disposal, where 80% of the hospital waste in general waste which does not require special treatment, provided it is not contaminated with other infectious material. Proper labeling of the bins is a must, and it should carry the logo or the symbol of biohazard or cytotoxic material or radioactive material on each and every bin and the banks, and it should carry the symbol indicating that the nature of the waste is hazardous to the patient and the public at large. Collection of biomedical waste involves use of different types of containers from various sources of biomedical waste, like operation theatre, laboratory, wards, kitchen, corridors, and other parts of the hospital. The containers and the bins should be placed in such a way that 100% collection is achieved. So we have to make sure that each and every part of the hospital, especially if it is a big center, a big institute, where the material can be collected and easily disposed and collected in all the bins. So adequate stations should be made. The sharps must always be kept in puncture-proof containers to avoid injuries and infection to the workers handling them. So it is our primary responsibility that we do take care of our own employees, so that they don't get injured and they don't succumb to the hazardous effects of the biomedical waste. Storage. Once collection occurs, then the biomedical waste is stored in a proper place. Segregated waste of different categories need to be collected in identifiable containers. The duration of storage should not exceed 8 to 10 hours in big hospitals where the amount of biomedical waste is much high, especially if the center is 200 to 50 bedded and above. And even in small and mid segment hospitals and nursing homes, the storage should not exceed for 24 hours, because it will create hazardous effects to the staff and to the admitted patients and to the visitors as well. Each container may be clearly labeled to show the ward or the room where it is kept. The reason for this labeling is that it must be necessary to trace the waste back to its source. So if there is any problem detected or any infection which is broken out, or if you really want to trace from where the material has come, so it's always better to label that dustbin or that container the place where it is stored. and the storage area must be marked with a caution sign so that general public, the visitors and your patients and the other people, they don't go into that area. If at all, if it contains an infective material, they might they catch the infection from the biomedical waste. So it has to be labeled. Color coding has been devised for biomedical waste in the hospitals, and segregated waste they are put in the color coded bins. Especially these are the few of the standard colors which are used. There's the red, blue, yellow, and black. I just want to elaborate this segregation. If you consider the red bin, the type of biomedical waste that can be used, that can be put in this red colored bins and bags, are the contaminated waste, especially the waste generated from disposable items such as tubings, bottles, intravenous tubes, insects, and catheters, or urine bags, so which might contain the infection but are disposable, can be should be disposed or should be segregated in the red bins. It can be disposed by autoclaving or microwaving, where your first intention should be to disinfect those materials or those particular waste items. And it is the treated waste to be sent to the registered or authorized recyclers, or for energy recovery or plastic to diesel or such kind of industries where it can be melted down and again reformed to a new shape. Plastic waste should not be sent to landfill sites, which is very important, because we all know that plastic is non-degradable and it poses hazard to the environment as well, not only to the animals and human beings, but also to the nature. So it has to be recycled, and before recycling, it has to be disinfected and then given to the proper authorities to recycle it. Then the blue bins, they should contain broken or discarded and contaminated glass, including medicine vials, ampoules, except those contaminated with cytotoxic waste. So general glassware should go into the blue bin, and the disinfection by soaking the washed glass and the waste from the primary intention is to make all those material sterile, or they should be disinfected first and then they should be recycled, or they should be dumped into the proper system. The most important is the yellow containers, and they can be used to segregate most of the material that we use as biomedical waste. So human tissues, organs, body parts, and fetus below the viable period is very important. It can be segregated or it should be rather segregated into the yellow bins and yellow bags. The mode of disposal for such kind of material is incineration or plasma pyrolysis or deep burial, whichever is applicable, and especially considering
here is a tight subscap. Okay, over the time, let me complete. Over the time, like since they are neglected,
Sangeet sir,
would eventually contract, right? So,
Girish, you can. Girish.
Or in other cases,
you can mute, sir.
Girish, you can mute.
How can you explain that you have not done anything to subscap and you are able to reduce that? What is the trick?
Girish,
okay.
Can you mute? Yeah.
Yes, sir.
Can you mute Sangeet? Yeah.
Yeah, it's done then.
Okay. Other type of waste which can be stored or segregated in the yellow bins is the soiled waste, like items like contaminated blood, body fluids, dressings, plaster materials, cotton swabs, bags, all these parts which are contaminated with blood and infective material has to be put into the yellow bins, and incineration is the best way to dispose them of. Then expired or discarded medicines, they should also be put into this particular yellow bins. Pharmaceutical waste like antibiotics, cytotoxic drugs, including all items contaminated with cytotoxic drugs, along with glass or plastic ampoules and vials. They should be put into this thing. The mode of disposal of all such pharmaceutical products is it should be returned back to the manufacturer or supplier for incineration at temperature more than 1200 degrees Celsius. So it's a good practice so that that we return all those medicines which are nearing expiry or they have already expired and they are of no more use to the patient or the hospital. So the best way is to send them back to the manufacturer and the supplier so that it goes back to the company. All other discarded medicines should be sent back to the manufacturer and disposed by incineration. So it is the responsibility of the supplier and the manufacturing company to dispose them of in a proper way. Okay. Chemical wastes, like chemicals used in production of biological and used or discarded disinfectant is disposed by incineration and plasma pyrolysis. That is the best way. The chemical liquid waste, it has to be also added into the yellow bins where the liquid waste generated due to the use of chemicals in production of biological and used and discarded disinfectants, silver X-ray film developer liquids, which were used previously, then discarded formalin, infected secretions, then aspirations, body fluids, liquids from laboratories, and liquid from floor washing and cleaning. They are also to be packed into the yellow bags. First, they're to be pre-treated to sterilize with non-chlorinated chemicals on site as per National AIDS Control Organization or WHO organization guidelines, and then they have to be sent to incineration. Same thing with the discarded linen materials, mattresses and beddings which are soiled with blood or blood products or infective material. They also need to be pre-treated and sterilized and then sent for incineration. Biological, biotechnology and other clinical laboratory waste like blood bags, laboratory cultures, stocks, or specimens of microorganisms. All these, they also need to be segregated in the yellow bags, and the mode of disposal is also the same. So the primary intention, the primary work that we have to do is not to allow all the pathogens to spread into the environment. So it is our primary responsibility to sterilize it and then send it for incineration. Then the black bins should be used for biomedical waste which contains sharp instruments, sharp metal instruments like needles and syringes with fixed needles, then needles from needle tip cutters, then burners, scalpels, blades, and any other contaminated sharp object that may cause puncture. 2 minutes. Yes, sir. This includes both used and discarded and contaminated metal sharps. And autoclaving or dry heat sterilization followed by shredding and mutilation and encapsulation in metal containers or cement concrete is the mode of disposal of this. And it should be sent to the local, what you can say is a municipal or corporation dumping grounds and for further disposals. Then the material used for cleaning is, as you all know, that brooms with specifications, at least 1.2 meters long handle, then dustpans to collect the sweeping material, the mops, various mops can be used. Especially now you have the round ones with the squeezing mechanism, and they can really clean the floor in a better way. And big centers, they use vacuum cleaners to clean the thing. Personal safety devices is a very important aspect that our staff members and the team members, they handle all the biomedical waste. So they need to be protected on a primary ground, and they should be given proper gloves, aprons, gowns, or various suits so that they don't they are not exposed to the pathogens and the biomedical hazard that poses. Especially masks and boots should also be worn during handling all the biomedical waste. So the take-home message is, why take a chance when we can change the things? So even though it looks a very minor and a very small or a neglected aspect, is equally important as a medical practitioner, that we not only take care of our patients, but we also should take care of the surrounding, the staff and the general citizens and the nature as well. Taking care that the infection does not spread to the nature and to surroundings. Thank you very much. Thank you for a patient listeners.
Yeah, thank you, Sanjay sir. Having a knowledge of bio-waste management is also very important, even we all for the surgeons, because it also prevents the big fine from the municipal corporations. Because a small mistake by even by the junior sister in the Nagpur, they put a fine of minimum 50,000, even for the small nursing home. So I think this small knowledge is very important to prevent this unnecessary trouble.
What I feel that COVID has made more awareness in the general public and in the hospitals and the municipal corporations, and especially during COVID times, the corporation was really very strict regarding the disposal of waste.
So are there any guidelines to fine for these small errors which we make? Sometimes they fine 10,000, sometimes 50. Are there any particular format in which they could rate the nursing homes and could impose fines?
I don't think there is a standard formula for that.
There is only one universal format which you are aware of.
Arbitrary.
Okay.
Yeah. So,
Saoji, is there any question here?
And I just want to ask questions. Very good talk and in detail, but whether it is possible to apply it for a small nursing home?
Yes, sir, very much. I mean, it is very easy.
We segregate wet and dry, and as you said, red, yellow, and black. But small nursing home, it is difficult.
So the best way is that we should have some stickers, and it's very, I mean, you get it on the web as well. If you download those images and make stickers and put it everywhere in your nursing home and hospital, just by visual effects, your staff will get trained that where to put all those things. So that is the easiest way. What I feel, and we also practice over here.
A simple way is to color code the dustbins.
Yeah, that is there, but which dustbin?
So you get dustbin of that color only. Dustbin of that color only.
Yeah, dustbin of that color, and you have to have a set of at least 4 dustbins. Yellow, red, blue, and black.
Thank you, sir. I'm the last batsman. So OT is my temple is now little bit distracted by the NABH guidelines and how important it is. So my last task of today's session is to talk on the NABH and its importance for the small nursing homes. So Sangeet sir, can I proceed?
Yes, please, please.
This is very important talk, because nowadays everybody wants some TP and all these affiliations, and whether whatever we are doing in our OT, whether those are with proper guidelines or not. So your talk will be very essential to highlight those points.
Correct, sir. So is it visible?
Yes.
It's full, not a full screen at the moment.
Play.
Okay, and is this moving?
Yes, yeah.
Moving, na? Okay. Thank you. Yeah, so so in my last 10 minutes, I would emphasize on the NABH and its importance for the small hospitals. So basically, the Indian healthcare industry, it is impacted by so many factors, by the corporate growth, by the business competition, medical tourism, insurance, as Pahukar sir has nicely mentioned. And finally, if you see that it has affected the patient expectations and the quality of the healthcare at the hospital is also affected. And finally, to meet these expectations, this lead to the formation of some national or the internal regulatory bodies, which is the NABH. So it's basically the India's healthcare governing body that ensures the quality healthcare and PLS patients. What is NABH? Many of us, they might not be aware, and some of the people, they think that it's a headache. So let's understand what are the things which are important to know about the NABH. If you have time, and if you have your own hospital, just go to the website, type the nabh.co.in, and you will find that some important information about the NABH, that it is the constituent board of the Quality Council of the India. It's not under any ministry. It's an autonomous body. It is also an institutional member of the International Society of the Quality in Healthcare, which is a big index in our functional system. Also, its logo itself indicates that it has been associated with the patient safety and the quality of the care. So it is not related to the local guidelines, local municipal corporation guidelines, like how much land you have, where you have made the construction, is it legal or not. They are not concerned about that thing. They don't have any things related to your property documents or anything related to the financial part of the hospital. They just see whether this hospital is able to meet the basic expectation of the patients or not. Do they have the quality services which should be at least minimally provided by any healthcare, and they have, and accordingly they have categorized into the many levels. So usually a hospital is certified by the local authority. This is a problem. I mean, this is the situation everywhere. Municipal corporation generally they give the registrations, and but to be very honest, there is no standard model is followed for the quality healthcare services. And after running 2 or 3 years of hospitals to get the services in low cost, to meet with the people affordability, the quality and the standard reduces after the permission. Infrastructure and the manpower of the many hospitals, they are not properly up to the mark level, and because of this, it leads to the formation of a poor healthcare system. Many of the fire safety fitness certified hospitals, they don't have the proper fire safety. Some of the bio-waste medical management, as Dr. Sanjay sir has nicely mentioned, but they don't maintain those proper discipline. You can see that the cannula is hanging on the IV bottles. This is not uncommon. And you can see a lot of unhygienic products in the casualty and the OT. And this is not new. NABH is basically a guide and verify the quality infra signages for the patient, patient's rights, doctor responsibility, and many more to improve the hospital standards and to avoid this kind of the bad quality services in the hospitals. What does the NABH accreditation means to the hospital? This is also important. It simply gives you the quality assurance according to the global standards, that you have now a certificate of running a standard hospital for the quality care. Also, that it testimony that hospital wishes to increase the patient's experience positively. It is a mark of international recognition, as I already mentioned that they have now been indexed by the International Society for the Quality Health. And it is a valuable to the hospital for the medical tourism. But the two important advantages for the people like us, the two important advantages, that is, first is now the people, they are getting more smart. Initially, the people, they were not aware about the quality index and the measurement of the quality healthcare services, but now the people are very smart. They know now this is the accredited hospital, so a footfall of the patient increases with this accreditation. People know about the NABH and its functional system. Second thing which is important for us is the rate for the NABH accredited hospital is higher in CGHS and in the Rashtriya Swasthya Bima Yojana and the many cashless hospital in India. So is the NABH compulsory for the cashless hospital? Yes. Now it is compulsory for the NABH hospital. Guidelines are still very vague. They are not put it in the mandatory forum, but if you get an approval the renewal of the approval after 1 year, they ask whether you are now the NABH certified or not. And what they say that the final levels, when you get a NABH final level accreditation, your rates could be up to 30% higher than the non-NABH hospital. This is how the private insurance company, they are now claiming. So it is important. Why many hospitals are not interested in getting this accreditation? Because it's a lengthy process. They think that it's a lengthy process, but now there are the many mediators, many the BMS people, physiotherapists, trained personnel, they are now converted as an NABH consultant. They can help you if you want really an NABH accreditation. This is costly, the people think, than running a hospital without the accreditation. Yes, this is true that if you are an NABH accredited hospital, you need little more money to run your staff to make the services according to the quality standard. Many changes in the infrastructure may need. ये OT यहाँ नहीं चलेगा, यहाँ से इतना distance छोड़ो, यहाँ पे ये safety protocol, the distance between washroom and the patient bed. These are all, things may require some change in the infrastructure, which again is a cost effective. Certified manpower. They don't certify any hospital having any nurses qualification less than GNM. They tell you to keep 3 RMOs on duty according to the shift wise, and it again increases the cost of running hospitals. Also, the annual maintenance cost of this certification is also too high, and that's why majority of the time small hospitals don't take interest. But customer is a king. Safety to the patients. NABH, it provides a uniform care and the emergency services to all at all time, and it enables well-defined facilities for the control of infection and the safety. So patients are definitely more benefited if they get services from the NABH accredited hospital. They get the services by the certified medical staff. Chances of getting small problems or the mistakes by the poor personnel, they are less. The right to the patients are respected and protected, and also the satisfaction is regularly evaluated. It is always good to put an NABH certificate on your first platform where the patient approaches to you first, because if a person who is able to understand importance of the NABH accredited hospital, if they see that I am getting a treatment in accredited hospitals, the sensible people, they behave differently and they relatively pay more and they feel more satisfied in certified hospitals. No doubt it is beneficial for the staff also, because staff in the accredited hospital, they are satisfied because it's a continuous learning, good environment, leadership, efficiencies and the competencies of the staff, they get improved. It improves the overall professional development knowledge, because these are all the regular programs, staff training. And the chances of having a mistakes and improving the accuracy, they are more. That leads to the improvement in the staff performance. So confident and the potential healthcare workers should be the part of the NABH accredited team. Of course, it is safety to the hospital also. There is a lot of benefit to the organization. They stimulate the continuous improvement, commitment to the quality care. They raises the community confidence. It provides the opportunity to the healthcare, which you need to the benchmark with the best. And finally, it is as good as the international standard, available as the highest authority in India. And accreditation also provide the empanelment and the TPA support, which we have already discussed. So why NABH? In short, for the patient, there is a decreased length of stay due to good quality services. Safety to the staff, best place to work. And safety to the hospital, yes, perfect paper and the legal work provided by the NABH make you away from the medical legal cases. And if you really follow the guidelines of those NABH guidelines, you can avoid many of the false and the avoidable claims by the patients. Recently, my hospital, Suyo Hospital of the Nagpur, is recently being awarded, certified by the NABH. And because I've gone recently through all these things, Dr. Gadegone sir has decided to give me this topic. Thank you so much. Thank you, Maharashtra Orthopaedic Association and Sangeet sir for the opportunity. Thank you.
Yeah, I think Girish, it's a wonderful talk. You are given the basic good guidelines. Anything more specific in operation theater which you need to have apart from suppose it's already existing nursing home and then it wanted to go for an NABH accreditation. They couldn't make any infrastructure changes probably which is now old. So very easy to get, I think, the entry level NABH for such kind of setup. But
So
can we
even-
get full accreditation? Yeah.
Correct. So even for the entry level, sir, you need to make some basic, I mean, the expectations. They work more on the patient safety. So they, for the entry level, they see your paperwork, your documentations, how you are maintaining the emergency drugs, how you are maintaining your OT staff. And they they do not compromise, even on the entry level, they do not compromise on the safety of organization and the safety of patients. So they look for everything in the OT. And majority of the people, you know, they are coming as a investigator officer. They belongs to the non-clinical or the paraclinical work like pathology, microbiologist. They are the pathologist or the microbiologist or the pharmacy people of the other institution. So they are more focused on the microbiological part. And for that, the OT is the main area where they put more concentration.
And how much cost it incur? Cost?
Sir, like basic fees for the application is 30,000 rupees. After that, you need to bear all the expenses of the investigating officer who is coming to you. And if you need a help of NABH consultant, you need to pay more. So generally we don't have time, so we put an NABH consultant who gave us the idea about how to keep the record and everything. So
how often is the inspection? Every time we have to pay the same amount?
When you been certified, it is the validity is for 3 years. But so for first inspection, you have to pay 30,000 rupees as an official fee. And as an annual maintenance, sometimes they come, sometimes they just do the online. They ask us to put all the, whether you have done the AMC or certification or the yearly updates of your instrumentation. If they are satisfied, they don't come physically for the inspection, but sometimes they do come.
Yeah, and nowadays the desktop assessment has made it very easy. You need to submit all your whatever the NCs or whatever the problems or whatever documentation which you have on their website. They will just go through it, and if they are happy with all those documentations, so they will not come for any physical visit for the second or third time.
Yeah, for the second or third, but for first time they always come.
They will have some physical. Yeah.
There are hospitals, once NABH, always NABH. They don't do again.
Other way. That is the other way you're talking. What Girish was taking a normal legal way.
But I think, sir, these accreditations certainly help because these hospitals become system dependent, not on individual dependent. Everything becomes protocolized. They do have their own individual processes for even for intracath insertion. You need to follow all those guidelines. So now I had started working in this JC accredited hospital. It's again a wonderful setup. And though the documentation is more, the formalities are more, but it is certainly much helpful in medical legal point of view, and there are no errors which usually happen. Even for prescribing a single injection in the OPD is a very, it takes a lot of effort, so many documentation which need to undergo. But I think that will help our medical fraternity in minimizing all these complications and medical legal implications which could arise.
Correct. And I think so I think all the basic, the requirements of the NABH are very important for, even I was thinking that I need to get a permission, so some of the things could be manipulative, but these manipulations are very important for the medical legal documentation also. Because if I would have not gone for the NABH, my X-ray AMC, my anesthesia trolley AMC, and they might be pending. So this is really helpful.
Everything gets
more than just a certification. If you really follow the important guidelines, it is very important.
Yeah.
Actually, I have the opinion that now henceforth or in the coming future, all these kinds of certification will be must because it is a national policy or a government policy, and it is more towards corporatization of our medical field. So
absolutely. Yeah, when I was making the presentation, I found the guidelines that in future upcoming years, every setup will be like, it will be
gradually they would have made it mandatory, I think, I suppose.
Definitely.
Gradually,
especially for cashless mediclaims and other facilities.
Cashless, it is mandatory, sir. It is mandatory.
So I think Girish, I think
it's not mandatory cashless. Even though if you see that if you are having a certification of NABH, it doesn't mean that they will adapt your hospital on their panel. It is not at all. They are adopted so many
other way around. Unless you have a NABH accreditation,
you cannot apply.
No,
you
it's
cannot have cash.
If you will go through the list of the which are attached to some particular insurance companies, you will find 50% of them, they are not NABH.
No, not that way. But if you are going for new experiment,
it is you are not getting any benefit. When you are applying to some insurance company, you are not getting any benefit if your hospital is NABH. They are not counting on that at all.
Yeah, but at least the leading companies, they see that whether it is accredited or not.
For cashless, it is must.
No.
So
my hospital is
only for a selected.
So they are just. I am having a lot of experience about these while applying to the various companies. Right side, you can see HDFC or Go National or United India and all that. But I keep on telling them this is NABH accredited. They say no. You tell me.
Although the guidelines are not universal,
what the lowest cost you will quote to the patient.
Correct, sir. But these all guidelines, they might be applicable for long-running hospitals which signs 20 years, 15 years, 20 years. But if you see the recent like empanelment, they always ask for the NABH certification. You are very right that you don't get any benefit in the rates, but in the final certification, you get little better rate than the non-accredited hospitals. And every year now they are putting a mail to all the hospitals that if you want a renewal of the continuation of the services, you need to go for the NABH.
Because now these 2 years are over, so I want to renew it and I want to go for the regular NABH certification.
Yeah, that's what.
But looking at my 2 years experience, I am not much happy. That's what I want to convey.
So because it is not like the regulation by the government of India, it is an autonomous body, so they cannot make it compulsory. But the trends are like the fully certified hospitals, they have relatively more weightage on the insurance company than the non-accredited.
I will quote you one simple
example. The insurance companies will prefer the NABH hospital rather than non-NABH. They would be given priority. Again, they do have their own waiting list in different regions. And then according to that waiting list, they will try to affiliate whether that requirement of particular specialty or number of beds or hospital is there or not. Then only they will go for this further proceedings. But the basic requirement NABH still remains. Though in the COVID, I think they had made it lax for 1 or 2 years.
I will just tell you one small example. There was the empanelment was going on for BSNL. Okay, what they are asking a certification from civil surgeon. I have given them a certificate of NABH. They said, no. We want certification from civil surgeon, whether your hospital is competent enough to carry out all surgeries. I was repeatedly telling them NABH certificate is much higher than that. It is a central government issued certificate. It is having more weightage than this certificate. So this is the concept present in the many of.
This is true,
is
sir.
There any minimum bed staying for NABH?
It is not minimum, sir. Even 5-bed hospital can get an NABH accreditation.
Entry level, they will get entry level. For final accreditation, we need to have a good number of beds and the kind of specialties which want to cater.
No, that is okay. For final, that is okay. For initial,
for entry level, it is for no beds.
Okay.
So we have finished the questions and we conclude.
Yes, I think Girish, that was a wonderful talk. Yeah, Girish, can you just give the concluding remarks, please?
So, thank you everyone for the wonderful second session. OT is my temple, and this time the topics were new and the faculty participation were really fantastic. Even the pre-recorded talk and all the talks, they were probably completed on near normal schedule. So it's almost 3 years down the line. We can come to the closing remark by Dr. Sangeet sir.
Yeah, thank you all the faculty for making efforts, excellent presentations. Probably you have worked for such a long topic because this is a non-orthopedic topic, what we are speaking on.
Yeah.
So we have to make a lot of efforts in collecting the photos, literature, finding out from various sources what we are presenting. So thank you for your efforts once again. And we can conclude now.
Yeah.
Somebody can stop the recording.
The only thing is that Dr. Gadegone has said that you also write down what you have really talked, so that he really.
Yeah, you have to have a write up so that we can have a book.
Yeah.
Right.
MOA guidelines. That's what I was also insisting in my talk.
So
we should have basic guidelines that can be there.
We'll have to edit our talk.
Can you stop the recording?
Yeah.
Anybody from Ortho TV? I think.
Ashok left.
Okay. So we can leave the meeting because otherwise
we'll leave the meeting.
Yeah. So thank you all. Thank you, Sangeet sir. Thank you, Girish.
Thank you, everybody.
Thank you, sir. Thank you, everyone.
Thank you, Bhandari sir. Everybody. Yeah. Thanks again.
Thank you very much. Thank you very much.
मेरे को पहुंचते पहुंचते होटल करीबन 8:30-9 बजे। ठीक। तो मैं ऑफिस ही आऊँ ना।
So Priya, we can stop the recording for the webinar.
ठीक। is in progress.
ध्यान दीजिए, अपने बड़े बैग्स को ओवरहेड बिट्स और छोटे बैग्स को सामने वाली कुर्सी के नीचे रख दें। सभी यात्रियों से निवेदन है उड़ान के दौरान आप अपने निर्धारित सीट पर ही बैठे रहें। धन्यवाद। May I have your attention, please? Please keep your big bags in the overhead bins and place your small bags under your seat. Please be seated in your original.
Hello, Ashok.